Yeah, bye-bye.
Hello. There. Hello, hi everybody. We welcome everybody from all parts of the world to follow this webinar that we have organized at Barts. Close to me is Carlos Corredor, which is eminent clinician and also ultrasonographers, quite full-rounded. So in Barts, we have been running lung ultrasound courses and echo courses, so we have got quite a strong interest on that respect, and we have been running course of lung ultrasound also for more than 10 years. So why the idea to create this webinar is just that the pandemic, unfortunately, gave us the opportunity to show how important it is to have a point-of-care ultrasound in something so important like a pandemic that affected the lung. So the clinician, as we know, all over the world, found themselves with a tsunami of patients, and they needed to take a decision, stratify the patients, and decide what to do with them. So we realized that the lung ultrasound and then the point-of-care ultrasound was extremely important in terms of diagnosing, monitoring, and even taking, the therapy of the patients in different settings. And this is why we decided to collate and put together experts from different parts of the world, and just to show our experience and to see how possibly could be prepared for a second pandemic. Hopefully not, but I think the information we gather from our experience, it could be definitely transferred to any kind of disease that will necessitate the decision making, quick decision making, and this is why point-of-care ultrasound, I think, is becoming more and more important in our medical setting. Okay, so then Royal College of Anesthesia in UK has given 5 CPD credits for people that wants to follow. I don't know how it applies for people from other parts of the world, but this is what we have got. Now I give the word to Carlos, who will also give you some information about the webinar and other information. Okay.
Thank you. Yeah, welcome. Thank you, Gianpaolo. Welcome, everybody. So yes, so this is our webinar marathon. So it is a marathon. So we're going to be probably giving our 5 hours of streaming, as Gianpaolo said, with experts from around the world sharing their experience using POCUS for managing COVID-19 patients. So don't worry, if you get a bit tired, you need to kind of disconnect, go to the bathroom, have a meal, go out for the afternoon or morning, wherever you are, because this is going to be recorded, and we'll make the recording available online. You get a follow-up email. We'd like to thank Intelligent Ultrasound, who has sponsored very kindly this webinar platform for us to use and share our experience. They are a company that that produces very good and realistic simulators, ultrasound and focus simulators, and you can visit the website. And we will be showing some of the products during the webinar. So in your control panel, you will have the option of asking questions. So the questions are fed to us, to the chairs and organizers of the webinar, and we can then ask you questions during our Q&A sessions at the end of each session. So yes, without further ado, please sit back, enjoy the webinar, and we look forward to your feedback and questions. So we kick off with the first session with my colleague Gianpaolo chairing. Thank you.
Hello again. So the first session will be the POCUS and early diagnostic and risk stratification tool. So I would like to introduce Luna Gargani and Giovanni Volpicelli, who are going to be the first speaker. Luna is a cardiologist at the Center National Research Council in Pisa, and also she's the chair of the accreditation in echocardiography for the European Association of Cardiovascular Imaging. We have been, Luna also has been working with us in the organization of courses in ultrasound from the very beginning. So I've known her for more than 10 years. same story with Giovanni Volpicelli, who is instead an emergency doctor, staff physician at the San Luigi Gonzaga University Hospital in Turin. Turin, as you know, also has been flooded by COVID, and Giovanni has got a huge experience in the COVID patients, but also is the editor-in-chief of the critical ultrasound journal. And as you probably know, he also served as the chairman of the scientific committee of the first international consensus conference of lung ultrasound. So it's a very eminent personality on this field. So I call Luna the queen of the B-line, and Giovanni actually should be the king of the pneumothorax, but actually you know much more than that, Giovanni. Okay. Okay, so please go ahead with your presentation, and we are looking forward to hear what you say.
Okay, so Gianpaolo, thank you very much for the very, very nice introduction. You know how to make me blush. So it's a pleasure to start this marathon, and considering how much out of it I am after the lockdown, I think you did a very good choice to make me run the first kilometers instead of the last ones. But apart from that, we have a lot of things to speak about today, and this is my disclosure. And I would like to start with something that I think is very important. And unfortunately, about 2 months ago, I gave a webinar still about lung ultrasound in COVID-19, and I showed this slide, and I really hoped that in June I could have much more information to give to the community, but still we don't have any robust data or very strong study up to now to showing us some numbers, some ground knowledge on how to build what to do in COVID-19 with lung ultrasound. So what we have is a kind of empirical approach based mostly on our previous experience on different diseases. Say that it doesn't mean that lung ultrasound is not useful in COVID-19. It's quite the opposite. We are here to share with you how many information lung ultrasound can give us, but we have to keep in mind that, again, this is the experience of many laboratories, of many expert people, but we are missing some very strong studies to have a bit more detailed information about numbers, about cutoffs, and to be really sure when in the management of these patients, lung ultrasound is really, really useful. Anyway, let's go on, and I believe that most of the audience here is quite expert in lung ultrasound, but it is always useful to go back to the main concept of what ultrasound means for the lung. And we all know that ultrasound in the lung acts as a kind of densitometer. So we have mainly 3 big patterns. We may have a pattern of aerated or over aerated lung, and ultrasound cannot distinguish normal aeration from over aeration. We have a pattern of partially deaerated lung where we see the B lines, and we all know that more B lines equals less aeration in the lung. It's a very rough correlation, but it is very strong and valid and very helpful in many different clinical situations, as you can see here, including interstitial pneumonia, which is a condition we have in patients with COVID-19. And then we have a pattern of total deaerated lung where we see some consolidation. So it is a very simple but very strong correlation between the level of deaeration and our ultrasound signs. And referring to this concept of deaeration, we can also build a kind of lung ultrasound score that can be used in this patient. I'm not going into details now because I know that Ania Schreiber is going to speak about this later in the marathon, but just to give you an idea that these physiopathological basis of lung ultrasound can also be translated into something that we use in the clinical practice. This score has been used especially in critically ill patients, in patients with a standard acute respiratory distress syndrome, but can be used also in patients with COVID-19, but not only. Okay, so if we ask which are the lung ultrasound signs that we may see in these patients, we can say that we can see all the lung ultrasound signs in these patients, but especially we can focus on B lines and consolidations. And if we go back to some of the publications, because I said there are not so robust data and numbers on lung ultrasound in COVID-19, but there are a lot of publication on it, but mainly review and papers giving advice on how to do the exam. So we can find a lot of literature anyway up to now to tell us something about the use of lung ultrasound in COVID-19. And as you can see, the main signs that you may observe in these patients are, to start with, the B lines. And B lines can be seen in these patients in all their forms. So it's a kind of festival of B lines in the pulmonary involvement of COVID-19. We may have both separate and coalescent B lines in very different forms. So for example, in this video, we can see that we have a quite regular pleural line here, and we have some B lines that can still be considered separated. But we may have more coalescent B lines, as in this video. And again, the pleural line appearance is not so abnormal. It's very important always to refer to the pleural line as a line and not as the pleura itself, because we know that what we see by ultrasound is not a real anatomical pleura, but it is the ultrasound depiction of it. So it's important to keep into our mind this differentiation, especially when sometimes we hear the term thickened pleura at ultrasound. This should be avoided, because what we see by ultrasound is not necessarily the real pleura. It's not the anatomical pleura. Okay, so this is very important to remember. So when we have these coalescent B lines, as in this case, there is something that can come into our mind from some figurative point of view, and Giovanni fantasy was quite good here, and he thought that this appearance of big bands of coalescent B lines resembled very closely a light beam. So as you can see in this picture, we have a big band of B lines. Actually, I know Giovanni doesn't completely agree to call this a band of B lines. It's a kind of artifact, a band with artifact, but it is very similar in the appearance to many coalescent B lines, going on and off from the screen with respiration. And actually, this is very similar to a light beam. You can find the definition of this sign in many publications, and it's a kind of quite specific sign for COVID-19. It's not, it doesn't mean that you find the light beam only in interstitial pneumonia from COVID-19, but if you are in a pandemic situation, as we are now, seeing this kind of sign can be really, really important and very specific for an early involvement of the patient. But let's go and see a few more examples of the light beam. Okay, so you see you have this band of hyperechogenic signal, which is very similar to some coalescent B lines, that can come from both a normal or very regular pleural line, and it tends to move a lot with respiration. And usually these coming back and forth appearance can be related, although again this is quite an empirical observation, can be related to a lung which is still quite compliant. So this is a sign that we usually tend to see in the early phases of the pulmonary involvement. And again, we have the light beam here. Another example, so this big band of hyperechoic signal coming from a more irregular pleural line here. So again, the light beam can be consistent with both more regular or irregular pleural line. And what we can notice in the videos with the light beams is also that they seem very, very strong spared areas. So we all know that in ARDS, in acute lung injury, we may have spared areas, which are area of completely spared lung, very close, attached to other areas of the lung that are completely diseased, and usually with B lines. So when we have the light beam, we often have this appearance very similar to the spared areas, which is, and again, consistent with the pathophysiological basis of the disease, because even if this is not a standard ARDS, and we could discuss about this for hours and hours, still we have a non-cardiogenic edema going on with this interstitial pneumonia. So seeing the spared areas is consistent with what we have observed with lung ultrasound for many years in the other disease. Another example of light beam, we have a light beam here, one here, one here. So it is quite easy to recognize once you have seen a few videos of that. Okay, so B lines in any forms, but not only. What we have in COVID-19 pneumonia, we also have many interesting features about the pleural line, because we may have sometimes a regular pleural line, again, especially in the first phases, but it is very typical to have an irregular or fragmented aspect of the pleural line. And again, we underline the word aspect, we underline using pleural line instead of pleura itself, because what we see by ultrasound is not the anatomical pleura, but is a depiction, a sonographic depiction of it. So as you can see here, we have a more irregular aspect of the pleural line, which can be more subtle sometimes, as in these cases, or can be much more clear in other examples. And you can see the light beams here as well. This is a light beam, and also what we see here could be called a light beam, because this is very typical in this patient. So it's quite difficult to find videos, especially in the early phases, which do not include a light beam. This is another example of somehow irregular pleural line. Of course, the alterations of the pleural line has to be quite clear. If you're not very sure, or if you see very subtle, small alteration of the pleural line, you can just not consider that. You have to see some signal. Otherwise, we are speaking about really ghosts instead of real signs. And these irregularities of the pleural line sometimes can be, as we were saying, more clear, more definite, as in this case, and we can start calling this pleural line like fragmented, not only regular, and with some subpleural alterations. Okay, so you can see that it's not only the line itself, but all the subpleural line spaces kind of irregular. And this video is somehow in between from what we have seen in the previous video with only regular pleural line and what we see with the small peripheral consolidations. Okay, so sometimes this irregularity of the pleural line can really yield a more distinct image of a small peripheral consolidation. They are peripheral because they touch the pleural line. They are small because they are different from the large consolidations, which can also be present in patients with interstitial pneumonia from COVID-19. And usually this definition of small refers to a width of about 15 to 20 millimeters. Okay, so this is a typical small peripheral consolidations. And of course, we also see a lot of B-lines, which represents maybe the perilesional edema around the consolidation. So all these features are very, very typical and often seen in our patients. But in these patients, we also see some large consolidations. So we see consolidations which are much bigger. For example, in this case, we have a basal consolidation. You can see here the diaphragm, and maybe this is the liver. You can observe an air bronchogram into the consolidation, and it's not so easy to say and to understand whether this larger consolidation can represent a sovra-infection, for example, a bacterial sovra-infection, or maybe it is just part of the pathophysiological course of the disease, because they are quite often seen in the patient, especially, of course, in the more advanced phases of the disease. And then we have pleural effusion. It's very interesting that in these patients, a large pleural effusion, as in this case, can be seen, but it's quite rare. So it's not so common to find pleural effusion that you can see in more than 1 or 2 intercostal spaces. It's more frequent to see like trivial pleural effusion that can be seen for a few millimeters in the context of a consolidation, as we have here. You see, when the patient is breathing, there is a large consolidation. Here it is appearing, and there is a small trivial pleural effusion around the consolidation. So all these signs can be altogether present in our patients. We have a quite typical picture here. You have the chest CT, and you have all the ultrasound videos around, and we see that we have some separated B-lines. We have the coalescent B-lines with the light beam. We have small peripheral consolidations. We have alterations of the pleural line, and we have larger consolidations and the trivial pleural effusion. We don't have a large pleural effusion, again, because it is quite rare. So you can find all these signs together in the same patient, especially in the advanced phases, because if you have less advanced phases, for example, in this patient, and you can see the chest CT, what you see in the beginning, it is mostly the B-lines, separated, coalescent, the light beams. As you can see in many of these videos, we have the light beam, and you can start seeing some irregularities of the pleural line. Although, again, in the very early phases, the pleural line can have quite a normal appearance, or you may have a quite normal appearance, for example, on the anterior chest, and a less normal appearance in the posterior chest, because usually the alterations start in the posterior part of the thorax. Here you can see also probably a very small peripheral consolidations. So a very few notes about some technicalities. It's very important to have a good image. A lung ultrasound for COVID-19 patient is not a very, very basic lung ultrasound. It's a bit advanced, so it's useful if you have a gain that is adjusted to optimize the visualization of the pleural line. And for the same reason, the focus should be put on the pleural line, so you can better see all the potential alterations of the pleural line. And you have to remember to tilt the probe in order to visualize as much pleural line as possible. And this is true both in the transverse approach or also in the longitudinal approach, as in this case. So here you see the pleural line very nicely. Here you only see a little bit of the pleural line. So you have to move your wrist, you have to tilt the probe to visualize as much pleural line as possible. You can find some summary of all these informations in this review on why, when, and how to use lung ultrasound. For example, the clinical scenarios where lung ultrasound can be useful. And there is also a comparative table to make a kind of lung ultrasound differential diagnosis between the COVID-19 pneumonia and other conditions that patients with acute dyspnea and respiratory failure may have, such as cardiogenic pulmonary edema, ARDS, and bacterial pneumonia. Of course, this differential diagnosis is not made only on the basis of lung ultrasound, but there are some interesting differences in the lung ultrasound signs that can be useful, at least to reconsider your initial diagnosis and see if the patient has something else. And I just take the opportunity of these last 30 seconds to show you this website, which is openlungultrasound.com, where there are some free videos about the basics of lung ultrasound. This is an open collaborative free space where people who is expert in lung ultrasound can share their knowledge. There is also a tutorial in English on how to use and how to do lung ultrasound in patients with COVID-19. And I would like to thank Gianpaolo for his very important contribution to the birth of this website, which in the next few months and years, hope is going to grow, also with the help of everybody who would like to contribute and send some useful information. So just to close, a big thank to all my colleagues who have literally risked their lives to scan all the patients in this month. And now I pass the microphone to Giovanni, who is going to put all these signs into the context of patterns.
Thank you, Luna. Thank you very much. Interesting presentation.
Thank you, Luna. I think you said everything, almost. First of all, thank you, Gianpaolo, for your kind invitation. As always, your initiatives are very, very good and very important. What I will tell you today is related mainly on a direct experience that we had, unfortunately, in these months, when we lived a real surge of a very strange disease, because I never saw in my life anything similar to what we experienced in these months. There was a surge. A surge means that there were a lot of patients coming to the emergency department suspected for COVID-19. Of course, COVID-19 is a disease that in some percentage of cases is just a very mild disease without any worry about the life of the patient and so on. But in a certain percentage, it gives a very severe pneumonia. So our role in the emergency department was just to triage patients and to understand who was affected by pneumonia. This is something very important to remember, to remind to people, because COVID-19 is not the problem. The problem is the complication of COVID-19, of course, and pneumonia is the main complication of this disease. So the role of chest imaging in this screening, in this triage, is crucial, of course. And CT scan remains the gold standard for us. But of course, CT scan cannot be done on any patient when there is a surge, because of course, when you have 100 patients per day suspected of pneumonia, you cannot use CAT scan on any patient. So the role of lung ultrasound is becomes crucial in this scenario. So Luna told us about the signs. And science is only a very small part of the problem, for one simple reason. It is common to any chest imaging tool. The reason is that the sign of the diseases in imagings are not specific most of the time. And the same is for lung ultrasound, like for CT scan. So in doing CT scan, we don't make the diagnosis 100% specific of the disease. And the same is for lung ultrasound. Some more time Luna spent to explain about the light beam. And the light beam, of course, like other signs of COVID-19 pneumonia, is not enough specific. Because you can see the light beam in a lot of situations, not only in pneumonia from COVID-19. But the light beam has something that is peculiar, that is quite important. It is clearly a sign of a very early phase, a very early involvement of an interstitial disease of the lung. And this is because the pleura sometimes is totally irregular, like we see in this video. And there is a very sharp limit between the normal lung on one side and this sign. That is typical when we have a very early phase of aggression, of involvement of the lung interstitium by an infective disease like COVID-19 is. And it corresponds to the images of ground glass opacities that we see very commonly in the CAT scan of these patients. That said, of course, I receive a lot of messages in the social media. Not so many, to be honest. Some people is insisting to say that, of course, the light beam is not specific, but no one said that light beam is specific of the COVID-19 disease. But it's typical. That is a different word to say. What means typical? It means that when we have a surge of the disease and we have hundreds of patients coming to the emergency department, when we see this sign, we have a reasonable way to say that the patient has pneumonia from COVID-19. And it works. And we are trying to demonstrate in numbers that it works. Signs are not enough. When you have to orientate yourself about the possibility of pneumonia from COVID-19, of course, you need to combine the signs all together to understand if the patient has a high probability or a low probability of the disease. Be careful, I don't speak about diagnosis of pneumonia from COVID-19. I speak about high probability, and this is the correct terminology that we should use, speaking about lung ultrasound. What are patterns? Patterns are simply the combination of all the signs that we can observe in pneumonia. And this combination is what gives the probability of the disease. So in other words, if you see B lines, this is not enough to make the diagnosis. The B lines must be combined in a specific way with other signs to give what we call it clusters of many signs altogether, including the light beam, of course, presence of spared areas, the pleural line that can be and typically is irregular, but also regular in some part of the lung. And these clusters should be, and of course also small peripheral consolidations, but even large consolidations seen especially in the base of the lung. All these clusters should be multiple and diffuse bilaterally to have a condition that can be called high probability of the disease. So when you are in the middle of a surge, the outbreak of the disease, and you are leaving hundreds of patients coming to your department suspected with symptoms suspected for pneumonia from COVID-19, and you do lung ultrasound and you see these clusters distributed bilaterally in multiple areas, you can conclude that the patient has a high probability of the disease. Another pattern is the pattern that we call it intermediate probability. What means? It means that you have a cluster, for instance, of multiple B-lines or even light beam, but it is only present in some focus area. So, for instance, it is only in one lung. In this case, the pattern cannot be considered high probability because the typical pneumonia from COVID-19 is a bilateral pneumonia, very patchy distribution of clusters that I told you, and I call it high probability. So in these cases, we speak about intermediate probability, and it is something similar to what happens in CAT scan. The radiologist, when you will do the CAT scan, will talk about indeterminate pattern when there is a pattern that is not typical, that is not bilateral, for instance. So it is just the same situation. And this probability, if of course, is lower than the high probability pattern. Then we have another pathologic pattern also. And this pattern, we call it alternative. What means? It means that it is typical of other conditions of the lung. For instance, when you find a large lobar consolidation with dynamic bronchogram, of course, this is not typical of COVID-19 pneumonia. And it is something that will allow you to diagnose something that is alternative to the diagnosis of COVID-19 pneumonia. For instance, this is typical of bacterial pneumonia. Other signs are, for instance, the presence of a large pleural effusion. COVID-19 almost never gives to you, especially at in the early phase, a large effusion. So when you find a large effusion, this should be considered alternative to COVID-19 pneumonia. Even B-lines and distribution of B-lines and the shape of B-lines can be considered alternative when, for instance, when they are homogeneously diffused bilaterally, and they follow, for instance, a gravity-related distribution that is typical of cardiogenic edema. I will show you some case later to understand this difference. Finally, we have the pattern that in this slide is called negative, but it is an error. It is not negative. We can only say low probability pattern. That is the pattern where the lung is shows regular sliding and A lines, or just a few B lines, but isolated or limited to, especially to the base of the lung. This pattern should be considered low probability. Why not negative? Because negative is CAT scan. So the gold standard is negative. But a negative pattern at lung ultrasound is just low probability because, of course, the sensitivity of lung ultrasound is inferior to CAT scan. So in this case, you will have a low probability pattern for pneumonia from COVID-19. Is it enough? It is not enough. It is not enough because lung ultrasound is a point of care, a clinical tool, And it is crucial, the combination between patterns and clinical situation of the patient. And in our experience, there are three phenotypes that are very important to distinguish and to combine with the patterns to have a different probability of the disease for pneumonia from COVID-19. The three phenotypes are the severe form. That means all the patients with signs of respiratory failure, any sign from dyspnea or exertion to low oxygen saturation to severe respiratory distress. All these patients are classified as severe phenotype. Then we have a mild phenotype, that is patients we suspected for the disease without signs of respiratory failure. So only with cough, fever, ageusia, and so on, all the typical signs of the disease. And finally, I think the most important phenotype, that is the mixed kind of disease. That is patients with pre-existing chronic cardiac or pulmonary disease. For instance, COPD patients, severe COPD patients, patients with chronic heart failure, fibrosis, and so on. So what is the point? The point is the combination between different phenotypes and different patterns that will give to you the possibility to orientate yourself in the management of the patient. Just some example. This is a patient presenting with respiratory failure, not severe, it's just a mild form of respiratory failure, showing the typical clusters, bilateral, and as you can see at CAT scan, this corresponds to the patchy distribution of ground glass areas without consolidation. Unfortunately, these patients, after 1 month, died because the disease was not possible to control. Another situation is another patient with a similar condition. I'm sorry, the video are not going. Anyway, very similar condition, but only limited to small and few areas. So there were much more lung spared by ground glass areas and by consolidations. The destiny of this patient was exactly the same of the other. So this patient complicated, was intubated, and after about 1 month, he died. So this is just to show you that at presentation, it is extremely difficult. I don't think there is the possibility to predict the destiny of the patient, at least when we talk about triaging the patient, so at the very beginning of the disease. Another situation, just to show you what means intermediate probability. This is a patient COVID-19 confirmed, presenting with just a mild situation, mild symptoms without respiratory failure, showing only just a normal lung everywhere, but only a focalized area with B lines, coalescent B lines and light beam, and some consolidation with bronchogram, with air bronchogram. So as you can see, the lung ultrasound corresponds exactly to the CAT scan. And as I told you, CAT scan was classified like indeterminate, and the lung ultrasound intermediate probability. Then the patient had positivity for the PCR and was discharged home and followed up at home without any problem. Another situation to show you just what means alternative pattern. This patient was admitted with a situation of respiratory distress, and the lung ultrasound was the one I show you. What is the difference with the others, the other patients? B lines were just diffused homogeneously bilaterally, and mainly B lines were separated one from the other, as you can see here. And the patient showed, this is the CAT scan that they performed. Not so much easy to distinguish, but the fact that the pattern was totally homogeneously diffused, there were some effusion, bilateral effusion, and the cardiac ultrasound was showing a clear situation of impaired left ventricle function. This patient was diagnosed as pulmoedema, cardiogenic pulmoedema, and COVID-19 swab test was negative. I think I finished. Gianpaolo?
Yeah. Thank you, Giovanni. Just checking if our microphone is back to life. Yes. So we had several interesting questions, Giovanni, and you were talking about the very sensitivity of the lung ultrasound, but not specific. Something that we noticed certainly in intensive care was the presence of subpleural consolidation. You might have seen a couple of papers where they were trying to see if the enhanced echo contrast would be able to differentiate lung consolidation from possible microcirculation impairment. Can you comment on that? Because that could possibly was quite specific of this disease. You know that it had quite a high thrombotic, prothrombotic feature.
I don't think in a storm like those that I showed you, it is possible with high accuracy to distinguish when the consolidation is due to an infarction, peripheral infarction, or a consolidation due to the loss of density, of increased density and loss of aeration of the lung due to the progression of the disease. I don't think it is possible. But anyway, I don't see the usefulness of that. I mean, what is important for us is to make the diagnosis of pneumonia. Maybe in the more advanced phase, so in the ICU, I'm curious to listen to other opinions. It is also important to stratify the risk, but we know very well that the thrombosis is part of the disease, and maybe the consolidations are a mix of the two pathogenesis, so inflammatory pathogenesis and infarctual pathogenesis. But I don't see the usefulness of distinguishing.
In a way, I think because, as you said, probably this kind of sign were more presence in intensive care, or maybe people had more opportunity to see them in a different environment. Probably the importance of that would be if you've got a feature rather than another one, you will treat that specific feature, perhaps with more anticoagulation, and understanding that maybe one of the issues in that specific lung was the mismatch of ventilation perfusion due to poor microcirculation instead than a consolidation per se. So I think probably there is no much evidence on that respect, but that was the contrast, echo contrast was used in a group that I think Adrian Wong and also Soldati in Italy, they have done a couple of papers. So I think it would be interesting probably to explore that. Certainly not in A&E, but maybe when the patient has been already sent, serious patients are sent to the intensive care.
No, but I'm not saying that it would be interesting and important to differentiate. I'm telling that I don't see the role of lung ultrasound in that, because it's too, I don't think it is possible to rely on lung ultrasound to distinguish and to decide not to anticoagulate or to anticoagulate a patient based only on lung ultrasound. I don't see this role, but maybe.
Luna, I have received another interesting questions about the differentiation of B lines from C lines, which apparently are a feature of TB. I've never came across to it. Can you comment?
So, generally speaking, B lines and C lines are different, irrespective of the disease, because again, all these signs are not specific. So we don't see the C lines only in TB. We call C lines actually those hyperechoic vertical artifacts that comes from the bottom part of a small consolidation. And sometimes even the small consolidations themselves that we call small peripheral consolidations, or we call pleural line alterations, are the C line, have been called the C lines themselves. This is part of the nomenclature that Daniel Lichtenstein introduced, which is very useful, sometimes a bit complicated. It is important always to know that B lines, to be defined as B lines, have to erase from the pleural line. So everything else that doesn't come directly from the pleural line are not B lines. But said that, we cannot actually make a clear differential diagnosis of disease according only to these features. I mean, the C lines are present in a lot of different disease. I mean, that they are a way to call the sonographic appearance of the irregular pleural line and what comes from the pleural line when it is irregular. So this is so non-specific, even for in TB. Of course, it is non-specific. So it's important to know the different features of the ultrasound signs, but then to know that you can find them in many different diseases.
Okay, so you were talking about the specificity, and actually I came across to a question that they said, obviously, you say in a situation where we are hit by a pandemic, all of the signs are signs of COVID probably, but when the prevalence of COVID has gone down, do you think that this lung ultrasound feature still would suggest a high probability of COVID-19 pneumonia, or you could see these kind of features in different kind of pneumonia?
Gianpaolo, why we need during a surge, why we need lung ultrasound? Because anyone living a real surge knows exactly that it is a great problem to orientate the diagnosis and to decide where to put the patient, where to move, isolate, yes, no. This is the problem. So we need something that is quick and what we said today is useful to make, to orientate in a moment when you have 100 patients and most of them are COVID-19, and there is no other disease in the differential, because we didn't see any other kind of interstitial pneumonia significantly in these days. We only saw COVID-19. Of course, when this will be over, we'll finish, of course, there will be no problem of space, of quick decisions, and you have your time, like the ordinary activity in the emergency department. And you will see a patient with this situation. There will be a list of possibilities and you will check one by one using serology, using CAT scan, using what you want, because you have time. But this surge taught us that it is important to make decision quick and to orientate all this crowd of people coming. This is the reality. Otherwise, there was no need to talk about the light beam, about the probability of the disease, and so on. It is linked just to this pandemic phase. Was I clear?
One question. Yeah, thank you very much. So there is also another question for Luna, if I can make. You were talking about severity of the disease, and we've seen also the cases. Unfortunately, Felipe Terran is not coming because he has been involved in an emergency this morning. So we have got a little bit of more time for a couple of questions, and then his presentation will be recorded and then hopefully presented in the second occasion. However, we can talk about the stratification of the patient in terms of severity. My simple question is, a patient comes to the A&E and you scan it, and then you start to see lots of B-line, then you do your aeration score, then can you decide according only to the aeration score where this patient is going to be, or how severe his disease is going to become?
So thank you very much for this question, because it's a very important point. The answer is no. To simplify the approach, but there are many things that can be said about this. So the aeration score is something we have tried to use in these patients because actually we never saw lung ultrasound in COVID-19 before this month. So what we have tried to do was to use something that has been standardized and used in a very similar condition, in a quite similar condition, which is ARDS, and try to see if it works in these patients. We still don't have the answer if this is the best way to approach these patients. From my experience, and I think Giovanni can add something on that, I'm not sure that just an aeration approach is the only one that can give you value with lung ultrasound in COVID-19 pneumonia, because this is just one aspect. And in these patients, we also have a very huge disconnection between the imaging and the clinical conditions. So sometimes a very high aeration score can make you think that the patient is very bad, and maybe it is not so bad. I also can add that in some preliminary analysis of our populations, actually it seems that the aeration score doesn't predict the need of the patients to need intubation in the further days. It's only a more general prediction score of death and how bad it is going on, but not specifically for the need of being intubated and ventilated. But this is very preliminary. Say that we can approach these patients again, not only analyzes the degree of the aeration, but we can see the different patterns. We can see the percentage of the lung that has been involved, that maybe can also be very important. So it's really crucial not to be strict and be very flexible, because this is a new disease and we don't have all those certainties. So if you ask me, it is valuable to have a aeration score, I would say yes, because of course it's better to have a number than not to have anything, or just a qualitative description, because a qualitative description in many situations cannot be so useful to categorize the patients and to pass the information to another colleague or to follow up the patient. But even if you have that number, which is very important, don't rely only on that number, because the disease is not only the aeration that we indirectly see with ultrasound on the lung. Okay, so it's a no, but still I would suggest to do that and to use it, because it's very useful to frame that patient. Then I hope that in the next few weeks and months we can have more numbers and solid analysis on what these scores can really tell us, and which is the best way to predict what's going to happen to these patients with lung ultrasound.
Okay, thank you.
Gianpaolo, sorry, there is a question from Shegan, and he sent me by Twitter, and it is interesting because he says, does lung ultrasound still have a role now that the pandemic is slowing? Of course, lung ultrasound has a role, but I can say to you that we saw the last positive patients in the 18th of May. From the 18th of May until today, we had no more positive patients. What means? It means that at the same, I never saw anymore the high probability pattern and the light beam in my patients. Many patients with COPD, with respiratory distress, acute respiratory distress, but no one showing the typical high probability pattern and the light beam. What means that the day when I will see in a patient with acute respiratory failure a situation like those that I was watching so frequently in that moment, of course, my conclusion will be different. I will be much more slow down the final diagnosis. I will not think the first diagnosis as COVID-19 pneumonia. I will be more careful, and I will try to check the possibility of a differential diagnosis, of course. But the role is, again, the ordinary role of lung ultrasound in the emergency department. That is always a crucial test for our patients.
Yeah, if I may add just a couple of sentences, I think it's really crucial here to understand the difference between the general role of lung ultrasound in patients with acute dyspnea. And of course, we know that lung ultrasound is a great tool in these patients. So all of us is using it, is going to continue using that. But when we say we want some numbers, we want some robust data, is to have the real help of lung ultrasound in a potential new pandemic situation where time becomes really a constraint. So of course we do lung ultrasound, we know it's useful, but we also can do the CT. But if we have tens and hundreds of patients coming together, in that situation we really need to have some cutoffs, to have some strong numbers, to be able to put patients in different management pathways and to assign a grade of severity of disease to the patient very quickly. This is what we still don't clearly have. But of course, lung ultrasound is useful to understand what's going on now during the pandemic and in general situations in acute respiratory failures and acute dyspnea.
But Gianpaolo, I'm doing your job. I'm looking at the questions in my Twitter.
They should write the question in here, so I think we can moderate.
That's okay. That's okay.
That's fine.
No, I mean, yes, Segun is very optimistic. I'm not sure the pandemic will be over. You know, we have to wait and see what happens in the next few months. We have a really interesting question for the experts in semiotics of lung ultrasound. So basically, the attendee asked that we widely use the term subpleural consolidation, but he says by definition all consolidations are subpleural. Shouldn't we call them something different, like peripheral consolidations? Wouldn't that be more anatomic?
I always use the term peripheral, always. Anyway, I get not angry against you if you say subpleural consolidation. I understand your language totally, so I don't need to tell you how to talk. Peripheral anyway is more correct.
Yeah, I agree. It is more to say that it's immediately under the pleural line. Of course, all of them are below the pleural line. Otherwise, it would be not in the lung.
And how about the eye lines? I think that especially as an early representation of the disease, people, especially a GP that has seen that in the community, a comment about loss of eye lines. Again, we are talking about nomenclature that probably should spend a bit of time talking about.
Eye line? What are they?
A lines, you mean A lines?
Ah, A lines, A lines.
Let me.
Okay.
Carlos has deleted the question.
So
probably A line, yeah.
Now, what is the question?
So what is the role of A lines? Is this the question?
Go on.
Apologies, my fault.
I think he was probably talking about lots of, we misread, and like an early representation of the disease, maybe was A line, I don't know. So sorry, just forget about that question.
Yeah, but anyway, A lines are normal with COVID or without COVID, or at least normal or over aeration, so no deaeration. So if you see A lines, you don't see any abnormality that can be related to COVID-19. Of course, you can still have severe emphysema and have A lines.
Okay.
Yes, Segon is reminding me that I wrote in Twitter, we should stop using the term subpleural consolidation, as all consolidations are subpleural. Okay, but I don't wanna really, when you talk about subpleural consolidation, I understand what you mean. So it's of course it's more correct when we write a paper. It is more correct to write peripheral. Just the last point that maybe I forgot to say, but maybe it is clear. It was clear, but I wanna say again. Of course, the same pattern in different phenotypes may have a different meaning. For instance, in mixed cases, an alternative pattern may not be conclusive because you need CAT scan most of the time in these patients. Whereas the alternative pattern in respiratory failure most of the time is conclusive because you may make a differential diagnosis with COVID-19 pneumonia. So this is just an example. Anyway, the combination of the patterns, the 4 patterns with the 3 phenotypes is totally variable, and the same pattern may have a different meaning, clinical meaning in different phenotypes.
Thank you very much, Giovanni. Thank you very much, Luna. I think we should now start to move on towards the intensive care session, which will be
first, I'd like to ask the audience a little poll. We're going to ask what is the POCUS? So just please give us an answer. Basic, intermediate, advanced, or if you are a POCUS master, if you are a Giovanni Proficieri, Gargani. So please give us your answer. And yeah, people are voting away.
réel, puis lui, il est plus rapide que Guest, là. Oh, attends une seconde. Je sais que ça ressemblait à Maisonneuve, mais avec des, tu sais, mettons, les seuls, c'est des trois, là, tu sais, c'est pas le même, là. Ça de même, t'as pas mis le cabri.
Could you please all mute your microphone in case you don't need to speak? Please mute your microphone.
Okay, let's have a look. We have our responses. Yeah, so we have a good spread, but I hope that our webinar, I think our webinar will cater for all levels of expertise in POCUS, because I think we are covering, like we saw in the last session, from the basic semiotics of lung ultrasound to the more advanced applications. So now, what I'd like to do is, before our next session, we're going to see a little video, a short video.
Lung ultrasound is increasingly being used in the assessment of patients with COVID-19 infection,
sponsor,
as it is a fast, repeatable bedside test using equipment that is relatively easy to disinfect. Intelligent ultrasound has added examples of the lung ultrasound appearances typical of COVID-19 infection to their BodyWorks POCUS simulators to enable clinical staff to practice and train in the use of lung ultrasound. Using a standard segmental approach, the different parts of the lung ultrasound is increasingly being used in the assessment of patients.
Thanks, Andy. You good to go?
Okay, thank you. Can you all hear me okay?
Yep.
Good. It is my pleasure to introduce a couple of speakers with a long-standing history of interest and involvement with lung ultrasound. Firstly, Anya Schreiber, who's in Toronto, and she will be speaking about the aeration scores, which we've been talking about up until now, and she'll be followed by Enrico Buero, who's at the San Giovanni Bosco Hospital in Turin. So I think rather than me talking, let's crack on. And Anya, over to you.
Anya, giving you control.
Yeah, can you hear me?
Yes, thank you. Go ahead.
Okay, let me share my screen. Can you see my screen as well?
Yep.
Yeah.
Okay, that's perfect. Okay, thank you so much, Andy, for the kind introduction, and thanks so much, Jean-Paul and Carlos, for organizing this webinar and for the invitation. And thank you, all of you, for being here connected. I'm so sorry I wasn't able to share my webcam, but I'm here. So welcome to the aeration score from RDS to COVID pneumonia. So I'm not able to advance with, sorry, the presentation. I'm sorry, I'm not able to go ahead. Is there a way to? Can you still see my screen?
Yes.
Yeah.
Yeah, we see.
I don't know why in the presentation mode I wasn't able to go ahead. Is it okay if I share like this? Can you still see it even if it's not a full screen?
Yes, that seems to be coming quite clearly.
Okay, I'm sorry. It's like, okay. So today we'll be talking about a general background on monitoring. The only problem is that I won't be able to see the video moving because in this way, sorry, just like, okay, now it seems to work. Perfect, sorry. So today we will be talking about a general background on monitoring aeration and about the two principal types of score that we generally use in ICU with their clinical applications. And then we will see how we can translate this potentially into the COVID-19 context. And finally, we will see the possible limitations of this score in this specific context. Let's begin. We already seen this with Luna very clearly, and we know that different degrees of aeration correspond to different artifacts, and that a progressive loss in aeration determines a switch from a pattern of A lines to a pattern of B lines, vertical artifacts, that become coalescent until a complete loss in aeration. That corresponds to a tissue-like pattern or a consolidation. Attempts to semi-quantify these changes in aeration have led to different lung ultrasound scoring systems, depending on the different clinical conditions of the patients and on the clinical setting, more acute or more chronic. But the most frequently used score in the ICU setting, as already mentioned by Luna, distinguishes 4 steps of progressive loss of aeration and actually originates from the conversions of the 4 patterns that we see. The 4 patterns of aeration earlier into numeric values, and in particular, a pattern characterized by A lines, a normal pattern of aeration with A lines or less than 3 B lines corresponds to a score of 0. While a pattern of moderate loss of aeration with more than 3 well-defined B lines corresponds to a score of 1. A more severe loss in aeration corresponding to coalescent B lines is scored as 2. And finally, as a complete loss in aeration typical of a consolidation corresponds to a score of 3. This score is assessed and computed in each of the 6 regions per hemithorax defined by the parasternal line, the anterior axillary line, the posterior axillary line, and the paravertebral lines, each divided into a superior and an inferior field. And the global lung ultrasound score corresponds to the sum of each region's score and can range from 0 if all regions are normally rated to 36 if, for instance, the lung is completely consolidated. Score. This score has been...
mode d'identification qui est l'antithèse de Marco. Parce qu'il faut rentrer dans la pièce, regarder les affaires.
Could everybody please mute their microphones? Could everybody please mute their microphones?
Tu peux le faire parler Nalo, mais juste quand j'avais monté le timer.
Carry on.
Okay, so as I was saying, this score has been successfully used in different contexts. For instance, in this case, when performed at the end of a successful spontaneous breathing trial in weaning, it was found able to predict the risk of post-extubation failure. And in particular, a score of 17 or higher was found to be highly predictive of post-extubation distress, while a score of lower than 13 was found to be highly predictive of successful weaning. So the amount of aeration loss during the SBT quantified by the score was found to be informative in terms of the weaning outcome. Other context, it was also used to monitor the effect of fluid loading on lung aeration in patients with septic shock and RDS. In this study, the lung ultrasound score was measured at baseline, at the end of volume expansion, and 40 minutes after. And there was a significant increase in the lung ultrasound score between baseline, and we can call this T1, and even more between baseline and 40 minutes after the fluid loading. So the main message in this case was that an increase in lung ultrasound score can be used as an early warning about the side effects of volume expansion and may guide fluid administration. Another clinical application which was used this score was in monitoring aeration in patients with RDS and ECMO. In the first study mentioned here, at the cannulation, all patients had a score of 15 or lower. And this was also the median score in the survivors that were able to be weaned off from ECMO in the second study. Here in the right panel, we have the first set of data are the weaned from patients that survived, that they were weaned from ECMO. Then we have the non-survivors that were weaned and non-weaned and non-survivors. And as we can see, at the time of weaning, as I said, we had a significant improvement in the score in the survivors, whereas a severe loss of lung aeration persisted in non-survivors, even if some of them were weaned from ECMO. But we will have the specific speeches about ECMO in a bit, so I'll just go ahead. So besides the first score that we have seen, we have a second score, which is called the re-aeration score. And this score is computed observing the changes between two conditions over time. And according to the magnitude of the aeration change, we can have a score change of 1 if the change is between, for instance, a normal condition and a condition of less than 3 B-lines, so a score of 1 of the previous score. Oh, sorry. Or we can have a score of 3 if, for instance, the shift is between a normal condition to a pattern of coalescent B-lines, or to 5 points if we pass from a normal condition to, for instance, a consolidation. And this score can be either positive if, for instance, if we have an improvement in aeration between the two conditions. So here we can see the blue arrows. Or it can be negative if we have an aeration loss between the two conditions, so going in the opposite direction. Where was this score applied? So it has been successfully applied, for instance, in monitoring the aeration or the loss in aeration following antibiotic treatment in ventilator-associated pneumonia. In this case, it was significantly correlated with the re-aeration measured in CT scan. And in particular, a loss in aeration volume measured at the CT scan of less than 400 mLs corresponding to a negative score of less than -10, while an increase and improvement in aeration at the end of 7 days of antibiotic treatment was associated to a positive score that ranged between, let's say, 10 and 25. In blood, yeah, 20, 25. Another clinical application was also in assessing the increase in lung volume induced by a positive end expiratory pressure, so PEEP in patients with RDS after a PEEP maneuver, a recruitment maneuver. In fact, the reaeration score was linearly correlated, significantly correlated to the recruited volume assessed with the PD curve method, as we can see on the left panel. And in particular, a reaeration score of more than 8 corresponded to a recruitment of more than 600 ml assessed with the PD curve method. Okay, this was a general background on how we can assess and monitor and semi-quantify the aeration changes in the lung. But how can we apply these scores and transfer what we have seen in the specific context of COVID-19? As Luna said earlier, actually, we use for COVID-19 an empirical approach based on our previous experience because nothing really specific has been published so far on this. So this is a proposed lung ultrasound algorithm for the assessment of ventilatory management of COVID-19 acute respiratory failure, which identifies different time points in the course of the disease, in which lung ultrasound and the score as well can be useful. We can identify a first time point, which corresponds to the initial diagnosis, a first assessment, and a first treatment. And at this time point, with the lung ultrasound score, we can identify the different patterns of presentation of the disease, as Giovanni clearly highlighted earlier, and the initial amount of involvement of the aeration loss of the lung, and the change, the transition between one stage, let's say one pattern to the other one, how it progressed the aeration, how it changes from an early and mild COVID to a moderate or a severe disease. This is a nice document produced by the Intensive Care Society that summarized the different pattern in just a series of clear pictures. But what factor do we need to consider in influencing the presentations and the patterns of the lung ultrasound? We can say that at least 3 factors play a role in influencing the pattern of presentation. And the first one could be the severity of the infection, the host response, and the pre-existing comorbidities and the physiological reserve of the patient, but also the ventilatory responsiveness of the patient to hypoxemia. And finally, also the time elapsed between the onset of the disease and actually the observation in the hospital. So when we insonate the patients after the onset of the disease. And the interaction of these factors actually leads to the development of different patterns that influence also the phenotypes. And this is true, and I borrowed this from popular Gattinoni's paper. This is true in terms of respiratory mechanics, but also in terms of lung ultrasound. And in fact, we can use the lung ultrasound score to identify the pattern of lung morphology because of its ability to distinguish between a diffuse pattern of aeration loss, equally distributed in all lung regions, and a more focal aeration loss pattern, predominantly in the dependent regions. Here we have an example of a diffuse pattern characterized by diffuse or coalescent B-lines. So we would say a score of 1 or 2 bilaterally in almost all the areas with subpleural or peripheral, small consolidations. And those patients are generally PEEP responders, and PEEP is generally increased until disappearance of B-lines in the anterior areas. They also respond to negative fluid balance. Or we can have a more focal pattern with the anterior regions that are tendentially normal, so a score of 0, and with lung consolidations, so a score of 3 in the posterior regions. These patients tend to respond more to prone positioning, as high levels of PEEP generally do not recruit the posterior consolidations and could lead to overdistension in the anterior areas. These two lung ultrasound patterns seem to correspond to the two phenotypes described by Gattinoni. So a phenotype L, characterized by low elastance or high compliance, low recruitability, and limited PEEP response. And a phenotype H, characterized by high lung elastance or low compliance, and with higher recruitability, which corresponds more to the classical RDS we are more used to face. And actually, one phenotype seems to progress to the other one, or at least can progress to the other one. And as we have this progression from one phenotype to the other one, and we currently don't know if this progression is related to mechanical ventilation or just to a normal disease progression, lung ultrasound score could be useful in daily monitoring for an early detection of this progression. And a daily monitoring with the score can also be useful to detect earlier the occurrence of complications, such as a pneumothorax or an overinfection and a development of a bacterial pneumonia, or even to monitor the change in aeration related to therapies. So I've reported here the recommendations of the guidelines of the Society of Critical Care Medicine on ventilatory and hemodynamic support in the different steps of evolution of the disease. And I've highlighted here in red where, based of what we have seen so far, the lung ultrasound score can play a role in assessing the aeration and monitoring the changes over time. And in particular, here we have a first attempt to treat the respiratory failure with high flow nasal cannula, or a short trial on non-invasive ventilation. And here is recommended a close monitoring for assessing a worsening of respiratory status. And lung ultrasound score can have a role in this close monitoring. But then progressing, even in all these other steps, we can use the lung ultrasound score in assessing the PEEP, as we have already seen, in assessing, in setting the PEEP and choosing the PEEP strategy, in choosing the fluid strategy, in monitoring the aeration and the re-aeration following a prone positioning, or following recruitment maneuvers, or even in case of ECMO. Here we have the same concept divided into the different stages of the severity of the disease. Here again is the beginning. So during when we need high flow nasal cannula, non-invasive ventilation, and here we have the different stages of the RDS, mild, moderate to severe, and rescue therapy. And again, I have highlighted in red the potential role of the lung ultrasound and in potential role of the score. And finally, we can also use it in the resolution phases in monitoring a progressive re-elation, a progressive disappearance of the B-lines, disappearance of coalescence, and disappearance of B-lines itself, until weaning. And according to the Australian New Zealand Intensive Care Society guidelines, actually in COVID-19, standard weaning protocols should be followed And therefore, we might speculate that we can use the same cutoffs that we have already seen in weaning to predict post-extubation failure or post-extubation success, even in this context. But still, we don't have clear data so far, but we just propose an empirical approach. And also, we can use the lung ultrasound to monitor the effect of the potential bridging therapy after extubation, so high flow nasal cannula and NIV. But also, the lung ultrasound score might be of help in classifying patients according to severity, and therefore in deciding maybe the disposition from the emergency department. Is in this paper, the use of lung ultrasound score was proposed. This is just a proposal, is nothing validating, and for sure we need further studies to confirm this possible use. But in this paper, it was proposed to use the lung ultrasound score together with clinicians' decision to supplement oxygen to help in the decision, in the disposition decision of patients admitted to the emergency department. So for instance, a mild score, a score of 1 to 5, together with need or no need of supplemental oxygen, was able to decide to classify into a normal, a mild classification and decide the disposition for the patient. Again, this is just a proposal and nothing has been published so far just to validate this. But strictly related to this, in the last slides, I would like to show you some preliminary results from Dr. Boero, who will join us in a minute, about the possible role of lung ultrasound score in actually predicting the development of critical illness in COVID-19 patients. Here I reported a recently published study developed in which a score, a clinical score developed and validated in China at hospital admission was used for predicting which patients with COVID-19 could develop critical illness. And here, critical illness was defined as admission to intensive care unit, as we can see here, admission to intensive care unit, need for invasive ventilation, or death. And based on the coefficients from a logistic model, they were able to identify 10 variables that were included into a risk score able to predict critical illness. Dr. Boero tried to improve this score with the means of the lung ultrasound score. First of all, tried to validate the Chinese score on a cohort on 157 Italian patients. And based on the Chinese score, 73% of the patients were correctly classified in this cohort according to the final outcome. So I mean, patients that were classified as having a high risk actually ended up having a high risk of, ended up like being needing either admission to intensive care unit, invasive ventilation, or death. Adding the lung ultrasound score to the Chinese score, there was a small but significant improvement in the ability of the score to correctly classify the patients based on the final outcome. We can see a reduction in the amount of the red dots, which are the patients who developed critical illness, in the lower part of the panel, which corresponds to the low risk. And also after that, it was able to build a new simplified score based on the 3 most predictive variables among the 10 identified by the Chinese score, which in this score were the number of comorbidities, as we can see here, a lung ultrasound score higher than 15, and the value of the lactate dehydrogenase on admission. And the ability to discriminate between high and low risk, as assessed by the ROC curve, was similar to the Chinese score. Therefore, we have a similar accuracy in discriminating between high and low risk of critical outcome with a score that is just easier to calculate simply and with no need of X-rays. So as Luna said earlier, it probably is true. So the lung ultrasound itself is not able to predict intubation by itself, but probably combined with other variables, it might have a role better than chest X-ray or other variables to assess and to predict the evolution of these patients. So stay tuned for the final results of this study. And finally, I just would like to mention potential limitation of the score in the COVID-19 context. First of all, we know that the pattern of focal coalescent B lines is common, as Giovanni and Luna highlighted, so the popular light beam artifacts. And we said earlier that coalescent B lines might correspond to a score of 2. But this is true, pay attention that this is true if this is extended to the entire scan. But if it is present only in a part of it, with a part that is preserved, it should be considered a score of 1. So in this case, the light beam should be considered a score of 1. Moreover, a weakness of the lung ultrasound score is that a complete loss of aeration that corresponds to a score of 3 is attributed to a lung region whenever the tissue-like pattern is observed. So independently of its dimension, which implies that we might not be able to assess an improvement. So for instance, if we have a reduction of the size of the consolidation, but the consolidation is still present, we will still score it as a 3. So we won't be able to detect an improvement just based on the score. And this is true also in the other sense, in case of an increase on higher loss of aeration. And lastly, it's important to correctly score the different regions, especially in light of the light beam and of the patch involvement and of some spread areas. It's particularly important to observe and to calculate the score in the oblique scan and not in the longitudinal scan, as we are able to see a wider pleural length. And this is particularly important in case of a score based on number of artifacts per scan. So just a quick summary. Today we have talked about the aeration and re-aeration scores, how they were successfully applied in predicting post-extubation failure in the pre-COVID context, in monitoring changes in aeration after fluid loading, during ECMO and during ventilator-associated pneumonia, and in assessing the effect of PEEP recruitment maneuvers. And we also have seen the possible applications in the COVID context, which now still remain an empirical approach, as we already said. But we also have seen its potential application as a predictor of clinical outcome. For sure, we need much more data, but there is this potential. But the most important thing that I would like you to remember is that the ultrasound scores can be appropriate for measuring changes in aeration resulting from any treatment aimed at increasing lung aeration or any condition causing lung deaeration. So we can always have new potential application in different contexts. So thank you for listening and joining us. I'm happy to address any question.
We'll take questions at the end. I think we'll probably move straight on to the presentation from Enrico. Thank you.
Thank you. Okay, thank you, Andy, and hello to everybody. Thank you for the other speaker for their presentations, and thank you for the invitation. So we will talk about the role of diaphragmatic monitoring in the COVID-19 respiratory failure. But first of all, why diaphragmatic monitoring in this patient? I take some data from the very UK experience because they are quite clear and quite easy to go through. And according to the last IPNARC report, in the UK, there have been more than 10,000 admissions to the intensive care wards, being the most of them patients who needed a respiratory support of different level. That means a basic respiratory support or advanced respiratory support. The advanced one was applied to the very half of the total amount of patients, and 80% of the advanced respiratory support started within the first 24 hours, suggesting how impairing were these patients when arriving to the emergency department, in particular during the peak phase of this pandemic. And the population to which we applied this respiratory support was a population constructed built by several classes of age, with a vast majority over 50 years old. And we know that the age is a strong predictor of the final outcome in COVID-19 patients. So we have to understand that we applied an invasive support mainly to a very, on average, older patient for a very long time. In fact, it was carried out by this report that the mean duration of mechanical ventilation lasted more or less 13 days, but having an interquartile range that goes from 1 week to up to 3 weeks. So it is quite a long period on mechanical ventilation, and we know that mechanical ventilation provides some disturb on the diaphragmatic function. In fact, people who comes to the intensive care unit may already present a diaphragmatic dysfunction on admission, or in most of the cases develop it while they are on mechanical ventilation. And what's more, even then, when they are liberated from mechanical ventilation, twice as frequent as the portion of them who still has the weakness limbs has got a sort of diaphragmatic dysfunction. So diaphragmatic dysfunction is a big burden problem in all the ventilated patients, but in particular into the COVID-19 patient. Why do this happen? This happens because the comparticipation of many causes. The first is the already said invasive mechanical ventilation, but this cause couples with medications that we typically use in this patient, such as corticosteroids and neuromuscular blocking agents that were obviously used for the very first days, but in some cases for a very long duration, such as patients who encountered a Meduri protocol or just a low dose corticosteroids for reducing the immune response in the COVID-19 cases. Moreover, always a sepsis could superimpose. Let's think about the patient who developed a ventilator-associated pneumonia or any kind of infection correlated to ICU care, and so developed a systemic septic shock or a systemic severe sepsis that goes towards a further dysfunction of the diaphragm, and obviously malnutrition. So with a quite complex pathway, we have an augmented proteolysis and reduced protein synthesis that leads to the muscle atrophy and the loss of contractile function of the diaphragm. That all in all we call as ventilator-induced diaphragm dysfunction, or VIDD. So VIDD is very important since diaphragm is the main respiratory muscle, and its dysfunction predisposes the patient to have a prolonged wheezing, prolonged mechanical ventilation, and what's more, it carries a higher burden of unfavorable outcome in critically patients. So we need a way to investigate the diaphragmatic function of this patient. And diaphragm muscle strength can be demonstrated classically by functional, physiological, and anatomical methods. But all of them require a lot of time or require collaboration by patient. And in this case, it is absolutely an away strategy, or they carry a radiation burden, or they lack reproducibility. So In the last years, it came out a strategy based on the ultrasound application to the diaphragm that carries information both on the anatomic and both on the functional side. So having the possibility to perform lung ultrasound and the diaphragmatic ultrasound to this patient poses the basis to a monitoring that is safe, effective, that has demonstrated to have a good inter-observer agreement, that the lack of radiation that is quite repeatable, and obviously it is bedside. So it allows a day-by-day assessment of this kind of patients. So there have been already some application developed and validated of diaphragmatic ultrasound, such as the application for the diaphragmatic paralysis and the post-operative diaphragmatic dysfunction. And obviously the search for the causes of acute respiratory failure. But what's more, we can use it in the weaning process, both for predicting the success and for assessing the causes of failure. And in intensive care bay, we can use also to assess the patient ventilator asynchrony, as shown in the image here on the right. And finally, for estimating the work of breathing, in particular on the NIV patient, and in particular of the case of acute exacerbation of COPD patients. So it's not a novelty, the use of diaphragmatic ultrasound. It has some applications that have been validated and are well established, and some other that are more speculative and more based on a very research scenario. But how do we monitor diaphragm by ultrasound in these patients? So we have mainly two possibilities. We can't go very deeply into the technique, arguing about normal values and so on, but we can try to summarize some focalized idea about the first one, that is the diaphragmatic excursion, and the second one, that is the diaphragmatic thickening fraction. So as far as concerned the diaphragm excursion, it is a technique that typically need the assessment by a convex or a phased array probe that uses the acoustic interface of liver or spleen, obviously, aiming to assess the motion of the diaphragmatic dome of each side, okay, pointing the probe toward the posterior third of the diaphragmatic dome. This kind of use of the ultrasound actually use the brightness mode only to check the image, but the real protagonist is the time motion. What we want to know is the amount of the diaphragmatic excursion seen during time, and so seen during the respiratory cycle. Very hypoic line just above the diaphragm will produce on the screen a wave that is the wave produced by the movement of the diaphragm and thus from the inflation of the lungs. And this wave has a typical fashion divided into a crescendo and decrescendo that are correspondent to the inspiration and expiration time, but also to the inspiration and expiration amount volume. So it been also demonstrated that the amount of excursion of the diaphragm correlates with the volume inflated and deflated from the lungs when compared to a time volume track on the ventilatory monitor. So it seems to be quite a promising technique, but didn't show to be so useful in predicting weaning. It has some sub-analysis that may be quite important, as there are the quantitative assessment of the diaphragm motion on time. While weaning is defined as the patient going from FRC, so from the functional zero capacity, to FRC plus divided volume, or on a second application when the patient is asked to make a voluntary, that means a short and sharp interval through the nose, that is a sub-analysis that allow you to assess the residual force of this patient, and is more or less like the PMI evaluation on the ventilator. And lastly, we can ask the patient when we can perform a volitive maneuver to take a deep breath, bringing his FRC to the total lung capacity. And the total excursion of the diaphragmatic motion track is correlated to the total lung capacity, and so tell us something about the functional reserve of this patient. That in the very dyspneic patient will tell us if the patient has got some reserve to still keep the spontaneous breathing, or if we need to intubate and sedate, going to invasive mechanical ventilation. So, however, even though diaphragmatic excursion seems to be very tightly linked to the respiratory physiology, actually it didn't match to demonstrate its usefulness in the weaning process, but it demonstrated to be useful in assessing just the ability of the diaphragm to move, actually. And in a normal case, that is the one on the left, the panel A, you can see two respiratory cycles with the diaphragmatic dome coming towards the probe, and so a positive upward movement of this very bright line, showing a quite normal, more or less 15-20 millimeters excursion of the diaphragm. In the second panel, you can see a diaphragm that lost its function of contraction, but that is not so passive to the negative intrathoracic pressure provided by the other hemidiaphragmatic dome. And on the third panel, you can see the visual diagnosis of the diaphragmatic paralysis. That is a very important diagnosis in the context of the weaning patient, because even though you cannot actually assess in the spontaneous breathing trial the readiness of the patient via the diaphragmatic excursion, you can furtherly check for the causes of the eventual weaning failure. And so diaphragmatic paralysis, or complete paralysis or partial paralysis, as shown in the panel B and in the panel C, are two causes of weaning failure that diaphragmatic excursion can very, very easily assess. The second application is the diaphragmatic thickening, and actually the diaphragmatic thickening fraction calculation. So to assess diaphragmatic thickening, we typically use the liner probe, because we are going to insonate very, very superficial tissues, because of we will insonate the patient the apposition zone. That means the zone in which the diaphragm runs very vertically parallel to the chest cage. And here the diaphragm is identified by the pleural layer and the peritoneal layer, which define obviously the diaphragmatic layer, that is the one wider in between. But what we really want to know from this scan are two measures. Actually, one is the end inspiratory thickness, and the other one is the end expiratory thickness. And these two measurements will carry out some information in this way. We calculate the difference between them. So we are going to calculate how much the diaphragm gets thicker while inspirating. And we will divide these calculations of the difference between end inspiratory and end expiratory thickness for the end expiratory thickness. Having this way a percentage of the thickness increase during the inspiration. This is very, very important measurement, because it has correlated very well with the weaning process. And as diaphragmatic excursion, and also as the lung ultrasound score previously shown by Schreiber, all the studies, all the relevant studies on these three methods were included in the only well-conducted systematic review and meta-analysis on this argument. And both diaphragmatic thickening fraction and lung ultrasound score were shown to be able to predict the weaning failure or the weaning success during or after the spontaneous breathing trial. And in particular, we had to identify the threshold, or mainly two extremely two extreme thresholds that are 20% and 36% being all the remaining threshold somewhere in between these two, who were able, when an assessment conducted on the patient demonstrated a thickening fraction above these two thresholds, to predict the possibility, the ability of the patient to avoid the reintubation after an extubation, or to pass a spontaneous breathing trial on PSV or T-tube. So there is quite an established role for diaphragmatic ultrasound when applied on this patient, onto critical care patient. But in the context of COVID-19 patient, to whom and when should we apply diaphragmatic monitoring via ultrasound means? Actually, even though there are a huge amount of literature published on COVID-19 patients, we know quite nothing about the diaphragmatic use of lung ultrasound and of ultrasound itself. But according to the previous experience, we know that we have a well-established application on patients on invasive mechanical ventilation, but also for COPD patients in particular, there is some literature showing good results for patients on NIV, and there is a little part of literature showing the use on non-COVID patients. That is not the focus of this presentation, but these remarks that diaphragmatic monitoring via ultrasound is feasible on a very wide variety of patients. And we need to time actually the application of the diaphragmatic ultrasound, even though we have no actually clinical guidance to stress a precise moment to do that. So as far as concerned the COVID-19 patient, taking this rough coronavirus infection timeline that shows the worst scenario of a patient that need the intensive care unit admission by the end of the 10th to 11th day, we actually saw that NIV application may come and may arise to be useful in the impairing phase of the shortener of breath to RDS development, and so diaphragmatic ultrasound can apply to this moment. This is quite speculative, as well as speculative the use for invasive mechanical ventilation to assess patient ventilator asynchrony. But these can be two very useful points for diaphragmatic ultrasound application. And obviously, there is the third point, as we already said, to apply the diaphragmatic ultrasound for the weaning process. So let's put everything into a clinical case. Okay, so let's see how diaphragmatic ultrasound can perform on a clinical case. We can see here GP. Oh, sorry. So I just start telling about the case, so we will see the clips. GP is a 69-year-old female who came to our ED after a week of symptoms from complaining just from fever, no cough, and no dyspnea, and not so relevant past medical history. And when she arrived on the very first part of the afternoon, she had a respiratory rate of 20, slightly desaturating or room air, and she has got some fever. But exams were not so abnormal, but showing an LDH that was a rise above the upper normal value, and the chest X-ray showed interstitial pneumonia. So first of all, she was put on nasal cannula, oxygen therapy, and that was enough for the day. But by the very evening of the same day, even though she didn't manifest any dyspnea, her saturation dropped again to 88%, while on 50% of FiO2. So as the rate increased, an intensive care consultant was asked. We asked her and decided to admit her in the intensive care unit, where she died at 3 a.m. of the being with a respiratory rate of 40, the use and a lung ultrasound score of 20 with some peripheral condition, very small, actually no effusion. At the period, we wanted to try to be very conservative on her being the management and monitoring very intensive. So we tried to start an IV trigger. And as far as concerned, the time zero diaphragmatic evaluation, she showed to have a quite mild reduction in diaphragmatic thickening fraction, but a quite preserved and conserved function. So, quite sorry for presentation clips. Yeah.
Enrico, unfortunately, the connection is not very good, and it's very difficult to follow because the
sorry for the video clips. I can just do something and to close up everything, because actually the story is that when she arrived, she showed some residual diaphragmatic motion and the thickening fraction of. Yeah.
Enrico, unfortunately, the connection is not very good. What we'll suggest, probably record your presentation and then we will add it up to the recorded webinar afterwards, because especially the last 10 minutes, it was very difficult to follow. Okay. Sorry about that. We'll have to go to questions now.
Yeah, okay.
Thank you.
Thank you to both speakers, actually. Unfortunately, I mean, there are a lot of questions coming through, and thank you very much to all the participants for those. We won't be able to answer all of them, but some of the eagle-eyed participants have saw in Anya's talk that both phased and curvilinear transducers were used. And the question really centers around, is there any difference between using those different transducers? Should we use one more than the other? Should we use them at different times? And does the use of one or the other impact on the overall score that you can generate from your lung ultrasound scan? And a question to Anya and perhaps any of the panelists if they have something to contribute.
So I would say that linear probe, it allows us to have a higher resolution of the superficial part of the lung. So it's great to see the pleural line and, for instance, the lung point in case of pneumothorax. But to see like pleural effusions and the extension of lung consolidations, I would suggest that either convex probe or a microconvex or even a sector probe would be better.
So we should perhaps be using a combination of probes to perform the complete examination.
So actually, I would say that just a convex probe would be, which is like the most used and the most diffused. Normally, when we buy an ultrasound, this is the first probe that is equipped to do ultrasound. Or so one or the other. I would suggest that if you have to choose among different probes, I would suggest with like either a convex, microconvex, or cardiac probe, not the linear probe.
Great. So a question for Enrico, and apologies that your talk we weren't able to see it to the end, but a question from the audience. asking about the variability in observations, intra-observer and inter-observer variability in diaphragmatic thickness evaluation and diaphragmatic thickening evaluation. Enrico, are you? Oh, he's gone. Any of the other panelists got a view on the variability? Oh, Enrico, you're back. Did you hear the question, Enrico? Microphone. Turn your microphone on. I can't hear you.
Yeah, okay, thank you. I was.
Okay. Did you hear the question, Enrico? About the degree of intra and inter observer variability when looking at diaphragmatic motion and diaphragmatic thickening.
Yeah, okay. No, didn't catch the question. I tried to answer. Actually, there are some studies addressing this question, because assessment of diaphragmatic excursion it's quite easy, but carries a burden of variability due to the angle on which the time motion track insonate the diaphragmatic dome, as well as in the diaphragmatic thickening fraction measurements. The variability is carried out by the fact that the diaphragm is not so homogeneous as a muscle. So you should perform at least three measurements and then average them to have a consistent evaluation between operators. Typically, what is brought about by literature is that there is a quite good consistency between operators. So as far as we know, we can take the measurements and the reported data as quite reliable, actually. And so with a learning curve that is quite steep, but need to have and to undergo some supervision, diaphragmatic ultrasound is a skill that can be taught quite easily and that can be performed only after some period of training.
Thank you. And could you remind all of us, perhaps, where is the best place to place the transducer routinely to assess diaphragmatic thickness and diaphragmatic excursion?
Yeah, okay. It's a very good question. For the diaphragmatic excursion, that it may seem more complicated. We have two very different acoustic windows. So as long as we use the right liver side acoustic window, we should put the probe on the mid-clavicular line on the cross point to the costal arch. So put the probe this way, that is quite somewhat similar to the point from which we try to find out the gallbladder. We can insonate through the liver, trying to insonate typically the bed of the patient, and with a degree that is more or less 30-45 degrees towards cranial and posterior part of the patient. It will provide us an image that is insonating the passage from the second to the third of the diaphragmatic dome. That is the easiest one. The difficult one is the one on the left side. The left side needs the acoustic interface of the spleen, and it is reported that up to 30% of the cases are unfeasible to be carried out on this side. When we use the acoustic interface of the spleen, according to Boussouge, we use a very lateral scan, trying to cut through the spleen from the very inferior pole to the upper pole, and so looking to the diaphragmatic dome on the left. So this technique needs two different applications on the right and the left side. As far as concerned for the diaphragmatic thickening fraction, it is quite easy. We have to identify the diaphragmatic apposition form. More or less, we can say that the zone is quite a polygonal zone between the anterior and posterior axillary line, with an upper limit at the 6th intercostal space and a lower limit to the 9th intercostal space, more or less. It depends obviously on the habitus of the patient, but at this level, with a linear probe, we can insinuate very perpendicularly to the skin of the patient with a slight pressure, just to move away just some of the fat tissue the patient will have at this level. And what we will find just below will be the diaphragm.
Thank you very much. I think I will hand back over to Carlos and GP to take us into the next session. My thanks to both speakers, to Enrico and Anya, for their talks. Carlos, over to you.
Thank you.
Thank you.
Thank you.
Thank you, Anya. Before going ahead with the following session, I just wanted all the people who are following the webinar to try the lung ultrasound score evaluation form that Enrico has created. And I think that will give an understanding of how we are in agreement with the monitoring of deaeration or deaeration score. You can use your barcode and with your mobile phone, or you have got also a link, and you can connect to a link and then go ahead. I think it won't take too long, and it will be a good way to assess ourselves, and hopefully then Enrico at some point in his life will let us know. Yeah. Thank you.
Thank you very much. Yes, I mean, you can acquire this with the camera of your phone now in the next few seconds. Or obviously, this presentation will be recorded and shared with you, and the link for the study will be included in the recording. So we carry on with our webinar, and now we go for our third session of the afternoon. And I'd like to introduce my colleague Rosalba, who is a consultant in critical care anesthesia and ECMO here at Barts, for the next session. Thank you, Rosalba.
Hi, Carlos. Hi, Gianpaolo. Hello, everyone. Thank you for organizing this wonderful webinar. Thank you for those of you who just joined for our session in lung ultrasound and ECMO. We have seen over the course of this pandemic a number of patients needing ECMO because they failed to receive conventional management. And in the next two talks, we'll see the role of ultrasound in managing those ECMO patients. I'd like to introduce our first speaker, who is Dr. Antonio, who is a specialist in anesthesia and intensive care and ECMO at Papworth Hospital in Cambridge, and he has a special interest in transthoracic echo, transesophageal echo, ECMO, and especially ultrasound in intensive care. For those of you who just joined the webinar, we're going to take questions and discuss at the end of the two talks. Thank you, Antonio.
Thank you, Rosalba, for the introduction. Thank you, Carlos and Gianpaolo, for inviting me in this great webinar. And it's a pleasure for me to be here, and it's a pleasure to talk actually about lung ultrasound in ECMO as well, because it's something the team here in Papworth, we developed in the last couple of years. So it's been an idea initially, and then ended up in being a project at the end. And I'd like to show you and share with you the result of this research project we did. Just a little bit of background, no disclosure. Royal Papworth Hospital is cardiothoracic, is a fairly busy cardiothoracic center. Is one of the 5 ECMO referral centers. We don't do only ECMO, but we do heart and lung transplant, pulmonary thromboendarterectomy, and a few other procedures. Of course, we have been, like all the major trusts, we have been busy during this pandemic. We've been busy with the ECMO, and we are used to manage patients on sorts of different machines on ECMO, not only on ECMO. Sometimes really strange things can happen while our patients are on ECMO or other devices, other VADs or other mechanical devices. What I'm not going to talk about today is the VA ECMO. Of course, is is clearly is a talk that will be more on ARDS, on respiratory failure, and on VV ECMO. And this is where we focus our attention and our research on lung ultrasound a few years ago. And especially we focused our attention on lung ultrasound for ARDS patients, so for patients on ECMO, but patients that were on ECMO clearly, purely for ARDS. We know the basics of ECMO, so with ECMO we can mainly manage that the ultra protective ventilation. We can play with the gas exchange as much as we want. We can play with CO2 and oxygenation house in the same way we can do it with a normal ventilator. Mainly we can give the lungs a rest, and meaning while we do the rest, we treat the patients as usual. And it's quite interesting doing lung ultrasound on these patients, because these are patients that are ventilated with ultra protective ventilation, so with a really minimal tidal volume, and sometimes they are not ventilated at all. So it's not really uncommon to see patients on ECMO not ventilated for days or for weeks, not having much of tidal volume for weeks. And we have seen as well, especially during COVID, that this could be protracted, could be continued for really several weeks. What were we doing usually in PAPOT? What was the imaging in PAPOT? As probably most of the centers up to a few years ago, the imaging that we were using were usual CT scan and chest X-ray. And as we know, the CT scan is the gold standard. All the patients on ECMO that are put on ECMO, retrieved from other hospital and admitted to PAPOT on ECMO, they receive a first CT scan at the start. And then we do several CT scans. I say several, but usually a patient imaging could be on ECMO for 2-3 weeks, sometimes more. And they might receive probably another CT scan, or a total of 3 CT scans. So as we know, is the gold standard, is the gold standard in imaging to assess the lung aeration, and there have been a lot of studies on alveolar recruitment with the CT scan. So it's a perfect imaging, but it's something that it does give us the first snapshot, which is the most important, but then it's difficult probably to repeat. And it's difficult to repeat not just because of high radiation or because of cost, all that stuff. A patient that is on ECMO is a patient that is sick, and is a patient that will need for sure imaging. But the problem is it's quite difficult to mobilize these patients, especially there are patients that are quite sick, unstable most of the time, and a trip to a CT scan is not the easiest thing to do. And it does require having a lot of staff members as well. So it's something that we really like to do. It's something that we must do when the patient starts his journey on ECMO, but it's something that then we might repeat once or twice. It's not something we can do every day on these patients. What we do every day on these patients is an X-ray, which we know is fairly easy to do, but it doesn't have a great sensitivity overall. So it's been lacking as well of specificity and sensitivity overall. So we know that we can have a global idea, we can have idea about aeration, but it's not that sensible in terms of showing the progress day after day. And yes, we do an X-ray. It's not a big deal overall, like a CT scan, but on ECMO patients, doing an X-ray, it does still require having 2 or 3 members of the staff. Again, it's an exam that we can do once per day, which it does give us another snapshot. It doesn't show us much about dynamics. And when we talk about dynamics, or anyway, something that we can do again and again and again, we of course we move to the ultrasound. And as we did with the cardiac ultrasound, the same thing is the lung ultrasound. So it's something that we can take the probe, we can scan the patient, we can re-scan the patient after half an hour, after 1 hour, once we tried a proning positioning, once we tried a different ventilation setting. So our idea of studying these patients on ECMO was exactly to apply the lung ultrasound that we have been applying in all the other patients as well to these sorts of patients. And trying to follow, starting from the gold standard for the CT scan on day 1, and yes, using still the X-ray because this was our practice, but along with the X-ray, with the daily X-ray, we wanted to do as well a daily lung ultrasound, sometimes even more than once per day anyway. I'm not going through why it's important the lung ultrasound today and what the evidence are around the lung ultrasound today, but what we focus on our research was specifically about lung aeration. So what we wanted to see was the degree and the distribution of air in the lungs, and how this air in the lungs was changing day after day. And the patient that stays on ECMO for 3 weeks, a change one day to the other, might not be really so obvious. So it might not be seen on the X-ray. And we know how sensible could
Antonio? Hello? Antonio, we can't hear you anymore.
I think we lost the audio.
Antonio?
deteriorating, or you see how they're deteriorating in a few hours. We started from the top range, from the worst range. So we scanned these patients with almost consolidated lungs. So it was pretty common for us to start with the worst imaging ever, or for sometimes as well the most satisfying for who was scanning, starting with pretty consolidated lungs, and then seeing how that patient was progressing, we could see more and more aeration, so more and more bilines. So just to make it clear, on the first day on ECMO, was really rare to see any bilines. So we were seeing consolidated lungs overall. And it started being quite of a entertaining study as well, because we started seeing imaging that we were not usually able to see. And this patient, for example, was a patient which was having probably a tidal volume less than 50 mL. And mainly there was no existent ventilation at all. And these were quite common imaging that we were seeing on day one, on the first days overall. And sometimes we were having sort of mixed images where on the X-ray, you could see on the X-ray where it wasn't easy to recognize whether there was a consolidation or whether there was an effusion. And sometimes we had the both of us, or we had even something more strange. So the pretty amount of imaging that we had quite a pretty imaging. We had a really good amount of strange, or anyway, unusual imaging for us. Then we decided to set this research, and the research was mainly to study with the lung ultrasound the role of lung aeration score, whether we could apply a lung aeration score in these patients on ECMO, and see whether the lung aeration score was telling us something different from what we were seeing daily with the traditional imaging. And mainly we wanted to compare what was our, the aim of the study was mainly to compare the use of the lung ultrasound in the aeration score with what was the gold standard. And the gold standard, as we know, was the CT scan. And we didn't want to put the X-ray completely apart, because this was our practice, scanning daily, almost every day, doing X-ray on these patients. So we wanted to take the CT scan as a gold standard. We wanted to compare as well the lung ultrasound with the X-ray, and to see whether there was any correlation between the three methodics. So we decided then to scan for a period of 6 months all the patients admitted to PAPOD, which were all patients over 18 years old of age, patients admitted through the ECMO service, so patients that were going on ECMO before admitting to PAPOD or as soon as they were admitted to PAPOD. And what we did with these patients was to scan these patients at their admission, and to scan these patients every day. So every day these patients were receiving a lung ultrasound. The team that was doing the lung ultrasound was a team that was not the clinical team. So was doing the lung ultrasound, was completely blinded to the CT scan result and to the X-ray, and what was doing was recording the lung aeration scoring on these patients. And looking at the literature, so we didn't create a lung aeration scoring. The lung aeration scoring, there are different scoring, but we took mainly from the literature, from the expert. And we decided then to base on that scoring, to give a score to our lungs. And we did a lung aeration scoring, starting from giving a 0 point to a normal lung, very unlikely on ECMO to maximum of 3 points when we were seeing a consolidated lung. So mainly if we had a patient on ECMO with a scoring of 0 or up to 5, that probably that patient wasn't an ECMO candidate, there was something wrong, but mainly highest was the scoring, was the lung appearance. So, and what we were expecting day after day was to see this lung aeration scoring coming down. And mainly we didn't look only to the lung aeration, but we then looked at the re-aeration scoring, just comparing day after day. So it was quite of a complicated scoring, but to make it simple was mainly we were looking at the aeration scoring. Highest was the scoring, worst was the appearance that we had. We decided to scan the 12 region using the methodic with the 12 region lung segments, so 6 for each side, 2 anterior, 2 lateral, and 2 posterior. Initially, we had quite of a discussion whether we should or not include the posterior zone, and whether a single operator was able to do a lung ultrasound in the posterior zone on an ECMO patients. And actually, it was pretty simple. It was much easier than doing an X-ray on these patients overall. Mainly to do a lung ultrasound on these patients, we took an average of 10 to 15 minutes overall, while doing an X-ray was taking a pattern more than having one operator. It took probably more, the time you were ordering to the time that you're having the result. But again, during the study, the two methodic were separated. So on a period from October 2017 to February 2018, so a bit less than 6 months, we had 30 patients admitted on to report on ECMO. And we said we only studied the ARDS patients. So we excluded 7 of those 30 patients, which were on ECMO for other reasons, whether they were transplant patients or whether they had cardiac problems, or they were not ARDS. So it was quite strict. Patient admitted on VV ECMO, is he an ARDS patient? So is he, according to the Berlin definition, is this ARDS? Yes, so included in the study. And then we had 23 patients. We had to exclude 5 because of family withdrawal or family did not give consent. So we went through the ethical committee, and the ethical committee wanted to have a family consent for this study, so which complicated in slightly the recruitment, but we managed at the end to have 18 patients included in this study. And you can see from the patient's characteristic and the etiology, so it's quite of a varied etiology that we had on these patients with ARDS. And have a look at the duration on ECMO. So the average duration of these patients on ECMO were 17 days. So 17 days means that every day we were scanning these patients, and we probably most of the time more than 1 patient on ECMO, from 1 to 4, and in the busiest time up to 6. So we had generated a big amount of imaging, and you see these patients had 18 CT scans. 18 patients, 18 CT scans doesn't mean that they had only 1 for each, but maybe some patient didn't have for some reason a CT scan at the start. And really in 17 days, yes, it's possibly patients had either 1 or 2 CT scans overall. But we did more lung ultrasound than we did X-rays overall. So I said that usually we were used to do daily X-ray, and we have been doing probably a little bit less than daily X-ray, but the amount of lung ultrasound that we have generated was quite impressive overall. And the results that we had were surprising in a way, but were reassuring for the lung ultrasound enthusiastic people, because what we had mainly was that we compared the lung ultrasound with the CT scan, and we compared the lung ultrasound with the X-ray. Comparing what? We did compare the aeration scoring, the lung ultrasound aeration scoring with a CT scan and the X-ray aeration scoring. And we did realize before or setting up this study that while we are not used to give an aeration scoring to a CT scan, to an X-ray, the radiologists are really familiar with aeration scoring on CT scan and X-ray. And here is where we had a radiologist blinded from the lung ultrasound and from the patient's history scoring CT scan and X-rays. And then we mix and match the results, and mainly we compare the 3 methodics, and we saw the that the lung ultrasound was the duration scoring scored with the lung ultrasound compared to the gold standard, the CT scan, was statistically significant. And the same thing, comparing the lung ultrasound with the X-ray, there was a strong agreement, a good agreement, I would say. So mainly, not only the lung ultrasound was comparable with the gold standard, but was comparable anyway with the X-ray. And actually, if we say we are taking the CT scan as a gold standard, what about the X-ray compared to the CT scan and compared to the lung ultrasound compared to the CT scan? Actually, the scoring we had with the lung ultrasound with a CT scan was much closer compared to the aeration scoring within X-ray and CT scan. So slightly, but again, we did not reach statistical significance on this. The lung ultrasound had probably a closer aeration scoring to the CT scan compared to the X-ray. There was a team of 4 to 5 people scanning, and we know that scanning means different interpretations sometimes, different acquisition technique and different interpretations. So we did standardize the acquisition. We did some intra-observer reliability, and we saw that there was a good correlation, a good inter-observer reliability and a good intra-observer reliability. So between the members scanning and mainly the 3 that we did this analysis between the 3 people that scan more than 80% of all the patients, and we saw that even doing rescoring our own scanning, we were probably quite pretty good. So we were accurate not only in reporting as well our scans, but as well in reviewing the scans as well. So what can we conclude from this study, from our experience? Well, we can conclude that then, yes, the lung ultrasound correlates with the gold standard, with the CT scan. And yes, it does correlate with the X-ray as well. We said that the result with the lung ultrasound were probably closer compared to the X-ray, but we can't say we should forget about the X-ray for sure. What we can for sure say about the lung ultrasound is that, yes, it is a real-time assessment, and we can use lung ultrasound to scan these patients for sure. And it's not something that needs to probably take the X-ray completely away, but it's something that could be used in conjunction. So in our experience, we wouldn't stop doing CT scan. So this is something that we are still doing. After 2 years after this study, these patients are all receiving a CT scan at the start, but they are not all receiving an X-ray every day anymore. So we are still doing a fair amount of X-rays on these patients, but some of the days actually, we are not doing an X-ray if there is no reason to do, because we are not looking at the aeration score with the X-ray only, but we are looking with a lung ultrasound. I would say the amount of X-rays we are doing in these days on these patients is much less. What are the limitations of our study? This study has been done by a core group of people, I said 4 to 5 people, which were pretty experienced on X-ray, on lung ultrasound. And for the amount of ultrasound we have done, actually, we became more and more experienced overall in doing this study. And it is something that needs to be applied to all the ICU settings, not the ECMO scanning, but the lung ultrasound scanning. So as usual, there is a learning curve on lung ultrasound overall. We did not have so many patients, but this is because of having ECMO patients is not, the numbers for an ECMO series is pretty high overall, but is a limited sample size overall. And this is a specific population. As I said, we started with the worst lung overall. So we are starting with the worst appearance on the lung with the lung ultrasound overall. So what can we do in the future? What we can do in the future from what we learned from this study, apart doing probably less chest X-ray and doing much more lung ultrasound in our unit, is probably that we can still apply the lung ultrasound for future project or prospects overall, because what we don't know is actually whether we said that is a dynamic tool, probably actually we don't know whether we can use the lung ultrasound before and after an intervention, which could be a proning positioning, it could be a ventilation adjustment on these patients, a recruitment maneuver, and to see whether that recruitment maneuver is effective or not. And this is something that open up the use of lung ultrasound on these patients, open up a lot of really project that could be done overall. And something that we wanted initially to do, but was probably too difficult, was to see whether we can use the lung ultrasound to sort of predict the weaning of these patients from ECMO. What we usually see, yes, this change that we see on the X-rays are fairly late change in terms of aeration, because what we see, the time that these patients are getting tidal volume, the X-ray is improving probably at least after 12 hours from the improvement, from the line compliance improvement on the ventilator. And probably the lung ultrasound could capture what we are not capturing with the X-ray overall. So thank you for the attention. And what I'd like to do is to thank Stephanie Curry, which has been working on this project with me, and I have to say, she has been doing probably a fairly amount of scan. I would say the majority of scan, the majority of the data collection on this work. And thank you everyone for your attention.
Thank you, Antonio. We'll take some questions for the end, and for now we'll go on with the next two speakers who will talk about our experience at Barts with lung ultrasound and ECMO. It is my pleasure to introduce Dr. Serena Rovida, who is a specialist in emergency medicine, who is currently working at Barts intensive care and has a special interest in lung ultrasound and had a significant role and commitment in teaching and education in lung ultrasound. And then we've got Dr. Shagan Olu Sanya. I never can say his name properly. Apologies, Shagan.
That's fine. You did well.
Yeah, trainee, a very senior intensive care trainee who has a passion in echo and ultrasound, and I would say is definitely the advocate for the use of lung ultrasound in intensive care. So thank you, Serena and Shagan.
Okay, thank you very much, everyone. Can you guys hear me?
Yes, we can.
Okay, perfect. So I would like to thank first the intensive care department to give me the possibility to stay for full 5 months, and then to liaise and to get along with the faculty for ultrasound, which is cardio and thoracic ultrasound in general at Barts. So basically what my goal in this presentation will be fairly simple. I just will give you some bits regarding the practical experience that we had, how we set it up, our faculty, how we decided which were the trainees taking part of the ultrasound scanning experience and so on. So the reason why we did it, I mean, we already saw through the presentation today why we're using it and what is the indication in the lung ultrasound application in ECMO patient and in general in ITU. So although the lung ultrasound has a role in ITU, which is confirmed, what is the role in the lung ultrasound for ECMO patients still need to be clarified. If you see the numbers in the slide, means the study and the relative sample size, patient sample size in each study, which is fairly small. There is the study, the last study at the bottom, which has been presented before with Ania, is a Xiao team et al. And it was actually evaluating retrospectively, is a retrospective pilot study evaluating VV ECMO patient, and they were actually trying to understand which is overall the mean lung ultrasound score at cannulation time and decannulation. Well, now the big data shows that it's about 14 to 16, and the two studies, one at the top and one in the bottom, was 15, and then the other study was 14. The cannulation time was 25 and 22 in the other study. And then the T1, which is the decannulation lung ultrasound score, is by around 14 to 16, the median score for decannulation. But still, a lot of information is still lacking and a lot of research needs to be done. So in our experience in Barts, we realized straight soon from the beginning that we need actually a call to action. So Bartolomeus is one of the 4 Barts Trust Hospital, which is providing, in this case, an ECMO service. We established from the very beginning 5 wards, COVID dedicated wards, and actually one of them providing ECMO, and basically we had admitted 120 patients intubated COVID positive in the last 3 months overall, but all the specific data will be released later on by Shigan. And then the interesting thing is basically all the respiratory medical team, cardiologists, intensivists, anesthesiologists pull together and work in this COVID ward. So there has been a team building and exchange of experience from many different backgrounds. As Antonio said before, the CT scan, of course, are the gold standard for investigation on non-parenchyma, but it was not possible anytime for a big infection control risk, and then of course for hemodynamical instability and ECMO service as well in this patient. So what we do basically, we decided we pull up this faculty, which is made of 7 members. All of these members actually defined some goals regarding the lung ultrasound. Lung ultrasound was done to improve the basically to better understand what was COVID behavior in these lungs, to generate data that could be then reviewed retrospectively for eventually research purposes, and of course for training purposes. So within the faculty, we will see later in a couple of seconds, we try to involve also the trainees that were both at the beginner or advanced situation, because we wanted actually them to liaise with us and to get this along with their ultrasound experience. So what we do within the faculty, which is made of 7 members here, we decided that all of them, of course, ultrasound trained for thoracic ultrasound. We decided that basically we need to involve the trainees, and which kind of trainees, as said, beginners and advanced in ultrasound, trainees coming from a ITU background, but also cardiologists and respiratory medicine registrar that were working with us. And the plus in this case for us was to involve the physiotherapy. That was really welcome idea, because physiotherapists are the ones sitting very close to the patient and seeing basically the patient improvement or worsening daily. So they can even find a correspondence in their improving or worsening in the lung ultrasound findings. So we found it actually very good for them to get even closer to the patient and to the medical team, and actually the feedback was very positive. Another deal was to have a one-to-one transversal learning, which is something that we really care about in terms of none of the trainees were left alone unless very advanced. In that case, if the trainees were very advanced, we review the image afterwards. But let's say 95% of the cases, we have been close to them, and basically we run a proper troubleshooting real time, trying to assess a better view, trying to get a better image, and also for image interpretation, because as Luna said before, the COVID lung ultrasound findings are not very easy to interpret, and then they come providing a lot of complication. So you can have consolidation, you can have pneumothorax, hydropneumothorax, hydroempyema as well. So we had a lot of very challenging images. And then, of course, this could help us to reduce the variability in between sonographer. For the lung ultrasound protocol, of course, it's been already discussed before, just a tiny information for the listeners. So the lung ultrasound that we used was not a straightforward decision. So we started first with the FUSIC protocol, which is basically 3 airs per hemithorax, but then we realized it was not proper for this kind of patient, especially because most of them are semi-recumbent, supine, and then, of course, acquiring the posterior area information is very, very challenging, but actually is the area where it happened the most. So we decided to use the Bohem-Mongardi 2015 ultrasound protocol and use the proper aeration score. So, and then what we did, basically, if we move on to, basically, we did also provide for every trainees a web platform where everybody was just would actually go in via internet and find some information, so videos, tutorials, and also we share some of them also in our WhatsApp group. So everybody that was participating to the scanning experience could actually see them in a remote control. And then another very challenging step we found through the 3 months was ensure a daily service. For daily service, that means that at least one of us, so one of the supervisor or mentor, were always there. That has been challenging, but I have to say overall, at least 5 on 7 or even 6 on 7 days a week, we could have it. So one of us was always available in one of the wards, and then via this WhatsApp group, we could communicate everybody, and then basically the mentor were updated, and then if a lung ultrasound were needed somewhere, it could come with the trainees and do it properly, deliver the service, and see what was basically the effect of the lung ultrasound in terms of monitoring or bettering, changing the ventilation setting, or changing, proning the patient, or doing any other procedure. So another challenge was, of course, the infection control, because there was words, COVID-free and COVID-free dedicated words. We had to have our proper ultrasound machine with our dedicated probe as well. So what we did is, for each of the 5 words, there was a lung ultrasound provided by 2 or rather than 3 probes. So the linear for the access as well, and DVT scanning protocol, and whatever the convex was not available, we used to use the cardiac or phase array as well to assess the lungs. So the infection control was also a burden that has been solved in this way, providing on each ward one ultrasound machine. This is a very short hour protocol, which thanks to Carlos Corredos, we had online actually. So every sonographer could go through this online form and then upload the form in the patient file. So this is very good because all the team could review it even the day after, and everybody had it even after 3 days when the lung ultrasound was repeated. And of course, for study purpose, is something documented and sitting in the notes of the patient. As you can see, ventilation setting and information, private information of the patient was on the document, plus for each area there were this score going from 0 to 3. Everybody knows here now 0 is a normal aeration score, which means that we can see the A lines or B lines less than 2 per area. And then the score 3 is the total loss of aeration, so a very severe score. So on top of this, the findings could be also described in the second page of this protocol, and then a conclusion was made every time. The very important thing was also the indication, so why the lung ultrasound was done, and then if necessary, why it was repeated, and of course what was basically the outcome if the ventilation setting rather than the proning patient was done. So this is very important. The last part of this presentation actually is this very interesting shared experience. So thanks to the relationship between San Bartholomeo's and George, so we decided every 2 weeks to meet up with the team online and run this meeting. There was a real troubleshooting, so whether we could sit and go through some of the image, very challenging findings in the patient, and see how the faculty from both the hospital or even the trainees interpret the image. That was very good in terms of could give also a sort of feedback how the things were going in both different environments, and how we could improve what was the pros and cons of doing lung ultrasound during these challenging times. So I just pass the microphone to Sega that will give you guys more practical data regarding our Barts experience.
Thanks, Serena. So I'm just going to talk specifically about the ECMO patients and what we found with lung ultrasound during our time at Barts. So I'll start with just some numbers and some demographics. So we had 18 patients in total. The mean age was 46 with a range of 27 to 59. So some of this will reflect the fact that we do have some selection criteria for ECMO. So you probably noticed that nobody's over 65, but at the same time, it's also a stark reminder that COVID-19 affected lots of different people at different ages. The vast majority of them were male. Most of them were supported with the VV ECMO. 2 patients actually had VA ECMO because they presented with cardiogenic shock from what we believe was COVID-19 induced myocarditis. They were eventually bridged to VV ECMO, and they actually, both of them actually did very well. And 2 patients were supported with VAV ECMO. So these were patients who presented initially with respiratory failure and then developed cardiogenic dysfunction while they were on ECMO, and we added an arterial limb to help bridge them through. And I believe they both did actually very well as well. The mean length of stay was quite impressive. The mean length of stay was 37 days, with a range of 14 up to 73 days, and 2 of these patients are actually still in ICU weaning. They're not necessarily in our ICU, but they are still weaning in other ICUs. The mean run length of ECMO was 17 days, with a range of 3 to 37 days. So we had 2 patients that were on for 5 weeks, and for more than 5 weeks. One was 35 and one was 37 days. And despite earlier reports of ECMO being universally fatal in COVID-19 patients, we proved that wrong, because out of our 18 patients, only 3 of them died. So we had an 83% survival to ICU discharge, which was really incredible. This is just looking at the lung ultrasound scores. So this is, I thought this was very interesting data. So the mean lung ultrasound scores, taking all of the lung ultrasounds that we did, comparing the different patient groups. So in COVID patients, the mean score was 23, with a range of 6 to 33. And this is including patients at various different stages, including patients who were ready to be weaned and extubated to patients who were still very sick. Comparing this to the COVID patients who didn't get ECMO, their mean lung ultrasound score was 19. And the non-COVID patients that we did do as part of the service, their mean lung ultrasound score was 16. And if we were to compare the difference in means, there was no statistical significant difference between the COVID patients who had ECMO and those without ECMO, but there was a significant difference between the COVID ECMO patients and the non-COVID patients, which did suggest to us that the patients who were on ECMO were really quite sick with quite sick lungs. This for me was probably the most eye-opening set of data that I've looked at over the last few days, and so I'll try and break this down. So each individual colored line represents a different patient. The y-axis represents the lung ultrasound score, and the x-axis is time in days. And as you can see, the x-axis goes up to 53 days. This is time in terms of time from extubation and progression. A lot of these. So as Serena's mentioned, this was quite difficult because this was an ad hoc service. So there were unfortunate gaps in the data. However, lots of these patients, so looking at, for instance, this patient in orange here, who had a lung ultrasound of 31 on day 7 and day 8, he was decannulated at day 11. This patient with a lung ultrasound score that went from 20 to 24 to 26 was decannulated shortly after this lung ultrasound score of 26. This patient who was here for a long time, whose lung ultrasound score went up to 24 at day 50, this patient died. As we can see here, there's actually no correlation whatsoever between lung ultrasound score and outcome, just as Giovanni alluded to in the beginning, where lung ultrasound score does not predict outcome, and we could not, I could not detect any signal for that in our limited patient data set. This is in complete comparison and complete contrast to the data from Mongodi, who did the original data looking at lung ultrasound for daily monitoring. And yes, this is on 5 patients. However, she showed a clear trend of patients surviving and improving lung ultrasound score, which showed an improvement in mortality, and patients who did not improve their lung ultrasound score dying. We did not see that in COVID patients at all. Also, what we also noted was some interesting additional findings aside from just the parenchymal changes. 2 patients had pleural effusions, one of which actually went on to develop an empyema. There was a pneumothorax which required drainage. There was a patient who developed complete lung atelectasis due to mucus plugging, and 1 lung ultrasound score was requested specifically to assess diaphragmatic function and readiness for extubation. In terms of therapeutic changes, the pneumothorax and the empyema were both drained, and the patient with mucus plugging causing complete atelectasis had a bronchoscopy which improved their aeration significantly. There were significant limitations of this study, one of which is the fact that it was an ad hoc service. There may have been a degree of inter-observer variability. However, when we had our meetings with the George's crew, we actually showed that there was a quite significant correlation between our ability to score different lung ultrasound images, and so overall, our scoring was quite consistent between sonographers. And of course, there are the national limitations of lung ultrasound in this cohort. So dressings, chest drains, body habitus, and in some patients, they were prone to, so we couldn't scan the anterior surfaces. And in patients who were on ECMO who couldn't be rolled, we couldn't scan the posterior zones. And just to finish off, I thought I'd just demonstrate a sample case and show you how we were implementing POCUS as a whole in our unit. So this is one of our ECMO patients, a 57-year-old gentleman. His story was he initially presented to his local, one of our local hospitals after a 1-week history of COVID-19 symptoms and turned out to be COVID-19 positive. He presented with this typically COVID chest X-ray with peripheral changes and quite significant interstitial changes as well. So it was initially managed with CPAP and self-proning. Unfortunately, he didn't improve. He was very reluctant to be intubated because of the risk of the, at that time, published high risk of mortality in intubated patients. So he had limitations of treatment placed and was managed with aggressive diuresis, but unfortunately didn't improve and was intubated eventually with, and was peri-arrest at intubation, was severely hypoxic post being intubated, was proned almost immediately and didn't really improve, and so a call was put out to us to come back and to come and retrieve him and place him on VV ECMO. This was his chest X-ray just before being cannulated on ECMO. And this is our standard technique in Barts. So we have a mobile team, usually a consultant and often one of the senior registrars, and we utilize a bifemoral cannulation approach, usually guided with echo at the bedside. Sometimes if we can get fluoroscopy, we will use that, but it's usually echo guided, and it seems to work quite well. And that's exactly what we did for him. Well, we brought him back to our units. We performed initial lung ultrasound, a baseline lung ultrasound, and echocardiogram. And these are images from his right lung, so showing, again, an irregular pleura, multiple B lines. And that was consistent pretty much throughout the right lung, except at the right base where he had quite significant basal consolidation. Moving over to the left lung, immediately looking at the left lung, you can already see that there is an area of consolidation that you can see right at the left upper zone. There's significant loss of aeration just beneath that area of consolidation. And here you can see that area of consolidation really well. So it's big, punched out, shredded area with air bronchograms within it, and it's spread all the way out down through the lung. and that's right at the base of the lung base, and you can still see some consolidation and significant loss of aeration. And this is his baseline echocardiogram. So left ventricular function actually looks preserved. There is some dilatation of the right ventricle in this parasternal long axis view. You can see some flattening of the intraventricular septum in the short axis view. Apical view again shows good left ventricular function, perhaps some slightly sluggish right ventricular function, but overall probably preserved. And here's a subcostal view that actually shows looks at the IVC, shows the right atrium, and you can see the return cannula. You can detect that because it's got multiple dots in it, just right in the IVC right atrial junction. And over here, right at the back, you can see the drainage cannula, and there's decent distance between them. This is about appropriate for initial ECMO cannulation. So for the first week, he was pretty stable on his current settings. From day 8 onwards, he started to develop worsening hypoxia. So he was switched to what's called a high flow configuration, where he had an extra drainage cannula added to inserted into the right internal jugular, which would allow us to give him even to increase the ECMO flows even higher levels, so therefore could deliver more oxygen. Despite that, he remained difficult to oxygenate, and there were worries that there was a degree of recirculation. So if you're two ECMO cannulae, your drainage and return cannulae are too close together, you basically suck out all the oxygenated blood that you're delivering through your ECMO into the drainage cannula. So we can monitor that at the bedside with by checking the difference in blood gases between the two limbs, and also by using transthoracic echocardiography to look at the distance between the two cannulae. And that's exactly what we did. And we repositioned his cannulae. This is a scan after an echo after repositioning his cannulae, and the first thing you can see here is that his lungs are actually worse, with worsening consolidation right behind the heart on the parasternal long axis view. Short axis view looks like you can see that the right ventricular function is actually preserved, and the dilatation appears to be reduced from his initial presentation, consistent with the effects of ECMO. And here you can see that the right ventricular radial function is still reduced. This is something that we see quite commonly in these people on ECMO. The apical four-chamber view shows good right ventricular function. And here, this is a subcostal view with color on, so you can actually see the flow coming in from the return ECMO cannula. So it's been pulled back from its original position, which was around here, to now lower down in the IVC. And the drainage cannula is even further down. And after we did all that, he actually started to gradually improve. We were able to find we detected from blood cultures and from sputum samples multiple bacteria. So he grew Klebsiella, he grew Pseudomonas, and we started to treat that with appropriate antibiotics. And he actually gradually started to improve. And we were able to demonstrate this on a repeat lung ultrasound on day 15. Which showed actually quite significant the development of A-lines. So this is his right lung. His right base is still consolidated, in keeping with being a supine ITU patient. His left lung, on the other hand, which was this lung that had significant consolidation, now has A-lines in it. So that shows a significant improvement in aeration, which tallied with a significant improvement in his tidal volumes. And that just shows more of the left lung there. And the left base, again, as expected with an ITU patient, was still consolidated. However, still had the irregular pleura, as you can see here, consistent with COVID-19 disease. Unfortunately, on day 16, he developed fixed dilated pupils in the early hours of the morning, and he was taken for a CT scan, which showed significant bifrontal hemorrhage. We also performed a transcranial Doppler at the time. We sometimes do that in our institution, which showed evidence of significantly raised intracranial pressure and loss of diastolic flow in the right middle cerebral artery. Following this, his family was contacted, and he unfortunately passed away a few days later. So if I were to conclude anything from our usage of lung ultrasound in the COVID-19 pandemic, it's very difficult to actually make any significant recommendations. It would be nice to be able to, in my opinion, I think it's just an extra data point that we include in our clinical assessment of the patient. And just as Daniel Lichtenstein says here, it would be wonderful to be able to manage patients without using ultrasound and just be clinically supreme. However, in times when it's difficult, I think the use of lung ultrasound and POCUS overall can add a significantly useful data point and can help with your decision making and help you manage patients. Thanks very much.
Thank you, Shagan. I've got a couple of questions. One is for Serena and Shagan with regards to what did we do with the ultrasound images? Were they stored and reviewed for Q&A purposes for training scans and governance issues?
So, can you hear me, Rose?
Yes.
Yeah. So basically, all the guys that were training with us are interested in lung ultrasound, and then what we did, and most of them they are taking either the FUSIC or the QSIC. That for the one that doesn't know, is basically part of the lung ultrasound portfolio for ICS, Intensive Care Society in UK. For the one listening from outside UK, and basically most of them have been. As I said, 90% of them have been supervised. Even the one that did, and they were most advanced level, has been supervised anyway. So the image before writing the protocol in the notes were, how do you say, were supervised and were discussed with one of the members of the faculty. That is absolutely necessary, especially in this kind of patient where there is very difficult to interpret the findings. Not just the challenging normal IQ patient, which is already challenging, but just because even small changes can trigger, actually can be a little bit difficult for even for the advanced one. That's why. And sometimes when it was not clear, even a review of the second member of the faculty was actually clean. So it was something that we used to do, like have a look to this image on the right. Zone 4 because I cannot get it properly.
Thank you, Serena. And Antonio, are you still there?
Yes, yeah.
Question for you. Do you think could a variation score have a role in deciding best timing for the cannulation, perhaps to reduce incidence of also the recannulation, or in other words, a second run of ECMO?
Difficult to say. This was probably our initial idea, but then we even didn't put this as a name because it was probably would have been too challenging anyway to show this. For sure, what we have seen in our practice in scanning every day, we have seen improvement and we have seen change in aeration score. What would be difficult is actually to see whether the change or what change would be statistically significant. So honestly, I think this one will be quite difficult. What we have seen sometimes was a big discrepancy between patients where we thought we could have been patients that could have been decannulated with not really good lung imaging. So or probably situation where mainly there were patients with acceptable gases. It's very easy on ECMO if the ECMO run is good, if there is no issues with the circuit, having good gases, patients which doesn't have major issues on the X-ray and looks quite good, but which with anyway something not right on the lung ultrasound. So I would say, just to make it simple, so the lung ultrasound could be daily monitoring, which you can use in these patients, making the lung ultrasound probably the tool that can predict the ECMO decannulation is possibly too challenging and probably isn't the role for the lung ultrasound. It's a tool added with the other methodics for sure, with the X-ray, with the CT scan, and with the clinical findings that we are seeing on these patients for sure. So I think if we would have set up our research like to see whether the lung ultrasound scoring could have predicted the decannulation, we would have probably failed. I see more the lung ultrasound as a good change. You do an intervention. So if you do a lung recruitment maneuver, if you do a proning, or if you do something else, rather than something that will tell you, yes, your patient is ready.
When you wrote Cabrini était dans le noir, I thought you were saying we couldn't see, and then we found the light.
It didn't look good.
I think please, whoever is not taking part to the Q&A, could you mute your microphone, please? And I've got other questions, but I've selected just two more for you, Antonio, please. Have you noticed any difference in lung aeration scores depending upon non-respiratory versus respiratory causes of lung failure in your general VV study?
Non-respiratory causes, sorry, what do you mean? Can you specify?
That's the question that I've received. So just if there is a difference in like patients who needed ECMO for other causes, I suppose, secondary to other organs.
No,
yeah. I can't hear you, Antonio. We can't hear you. Antonio? We can't hear you.
Yeah. We lost Antonio for some reason.
Yeah. Antonio? I'm sorry. I think Carlos, can you contact?
Yeah, I'm trying switching on and off his microphone.
Okay.
Oh yeah, you're working now.
So
yeah, it always works. Sorry, Antonio, the microphone went off.
So mainly, I don't know, because we did study only patients with ARDS, so we did exclude from the study all the other patients, actually. So the answer is we didn't see patients with non-respiratory causes. We didn't include if the reason was the ARDS. If the ARDS was secondary to pancreatitis or something else, then no, we saw the same thing that we've seen in primary ARDS.
Perfect.
And did you ask another question?
The last question from the same person is whether you had a reduced number of CTs and if there was a clear cost saving associated with it.
It's difficult to demonstrate that. In the way CT scan, the answer is no, short answer. So is because anyway, on a patient that on average stays for 3 weeks on ECMO, we do probably from 1 to 3, let's say, CT scans, and we didn't show any reduction in CT scans. We did indeed see a change in X-ray. What I think is difficult to put the advantage of using lung ultrasound in terms of costing and even radiation. Initially, I was really enthusiastic and say, we do lung ultrasound, we will show that we will do less X-rays on these patients. Yes, we do reduce the number of X-rays, but is not for the advantage is not having less radiation, I think, because anyway, at the time you do a CT scan on these patients, you anyway give the radiation that you would give with more than 500 X-rays overall. So even if in these patients you reduce of 5 or 6 X-rays, it's not that the risk. And ECMO patients are patients anyway where you are spending a lot of money with other stuff, with the ECMO as well. So we decided not to put anything in terms of cost in showing any sense of cost. What I think is the real gain as well, one of the real gain is actually staff, because to do a CT scan on these patients, the time you mobilize the patient, the time the CT scans is waiting for you, and it takes hours. And this anyway a risk, especially on COVID. During COVID, we have seen patients with really sick patients on ECMO, where we were really scared of moving these patients for a CT scan. And sometimes, yes, we decided not to do a repeated CT scan, but to do a lung ultrasound just because we would have not done the CT scan because we would have been dangerous. So mainly to do the lung ultrasound, it takes one person. And sometimes you can have the same answer of other investigations. Even to do an X-ray, you need to mobilize the patient, and you need to have 2 to 3 people to do that anyway.
Thank you, Antonio. That's very good. And I'll pass again the microphone to Carlos and Gianpaolo. Thank you again, everyone.
Thank you.
Thank you, Rose. So yes, our next session is chaired by Stephen, one of our critical care and anesthesia colleagues, who is also an echo guru. So please, Stephen, thank you.
Thank you, Carlos. And I'd like to start off by doing a poll before I introduce our speakers. So the first question I want to ask is the audience, is focused echocardiography sufficient for answering most cardiac questions in COVID patients? Yes or no? Interesting.
Yeah.
So, right down the middle. Okay, so on that note, perhaps some of my fellow speakers will be able to answer some of that. So I'd like to start off by introducing Dr. Jonathan Aaron. He's a consultant in intensive care medicine and anesthesia working at St. George's Hospital. He is a member of the FUSIC committee for the ICS and the College Tutor for Intensive Care Medicine. And as well as this, he's a very enthusiastic ultrasonographer. So I'd like to ask him to talk today about echo-guided decision-making in the hemodynamically unstable COVID patient. Johnny, over to you.
Hello, thank you very much. I just want to make sure I get the technology working. Can you see my screen?
Yeah.
Yeah, brilliant. Okay. Right, thank you very much for asking me to talk on something that I am very passionate about. This is a talk really about the utility of echocardiography in the intensive care unit. Interesting to see the responses from that poll there. So, I beg your pardon. So I'm an intensive care consultant at St. George's Hospital, FUSIC committee member, and I also teach on a lot of courses through our organisation SLICE, and I've had educational collaborations with various organisations. I want to tell you a story, and it should have been a good story, but it kind of wasn't. It's our experience at St. George's Hospital. And here we looked after nearly 200 ITU patients with coronavirus. We started off with 50 level 3 beds, so that was quite a jump. We performed 150 echoes in this cohort with our POCUS team that we created for the job. And we've obviously contributed a lot our data to various databases for collaborative work. Now, a lot of the title decision making in intensive care, obviously there's very little data associated with that. So I'm going to tell you the story that we experienced here. And you're all very familiar with it. It was a disease of initially respiratory failure with an X-ray that looked a little bit like this to start with, but then very soon became an organizational nightmare where we had more and more patients coming through the front door. And the organizational aspect of it became almost as challenging, if not more so, definitely more overwhelming than the medicine. And you all know it, I know it, despite our best treatment and what we thought we knew, X-rays progressed and progressed and things got worse and worse. And it made everyone very upset. Now, you know that this is what they look like when they come to you. They're on a ventilator, they're being moved, and it happens again and again and again and again until your unit is full. But I think it's important that we go back in time to an individual patient, and they start off sick at home, and they spend days at home before they come to hospital, and then they spend days on high flow oxygen, and then nasal oxygen, and then CPAP before they get intubated. And we know this because various papers have presented this data in more scientific format. So by the time they get intubated and are really sick, almost all of them, I don't know about everyone else's experience, almost all of them needed some noradrenaline. So they are therefore by definition shocked. And you dust off your old textbook and you know the differential diagnosis of shock. So we justify this NORAD requirement. They're hypovolemic and dehydrated because of their length of their illness. They have reduced vascular tone because they are hyperinflammatory and you know, their temperatures are high, and that is the condition. And also they have very high sedation requirements, crazy high, and that actually has a very significant effect of inotropy and vascular tone. And wait a second, we know from the literature that being dry is good, don't we? We have trials in it, and then these trials have been replicated and confirmed and fit into guidelines, and before we know it, trials in conservative fluid strategy versus liberal become a strategy involving drying the patient out. And I think that's probably not the same thing. So I think we have to remember that the trials were conservative versus liberal rather than actively negative. But overall, we think dry is good. So we do echoes in these patients because they're now on noradrenaline and they are shocked, and we just want to make sure nothing else is going on. And this is a typical early COVID echo in someone who's relatively healthy. So it's a hyperdynamic appearance of the left and the right ventricle, and all the measurements would predict a fluid responsive state. The TRV max is always slightly elevated, between 2 and 3 meters per second, and it's really unclear what to do with that, but we can justify it because it's difficult to interpret in such a hyperdynamic state, and we know they all have hypoxic respiratory failure, which can put up your pulmonary pressures. And looking at the left-sided indices, and here for those of you who would like to know the more details, we have the mitral inflow pattern, and the E wave is high, above 1 meter per second. We have tissue Doppler, and the E prime is also high, and we have the left ventricular outflow tract variation over the respiratory cycle, and the variation is high, in this case 30%. So even though we predict fluid responsive state in this patient, the teaching is you keep them dry. And actually overall, there appeared to be very, very little effect or correlation between oxygenation and fluid balance. So you dry them out, absolutely no effect on their oxygenation. But what there was an effect on was a very high AKI rate. At George's, within the first 2 weeks, it was somewhere in the region of 35 to 40%, much higher than we were expecting. And I think it's important to remember that hypovolemia, second dehydration, is a predisposing fact for intravascular thrombosis. And certainly that's a feature of this disease, which we'll discuss later. So I think overall, an overtly dry strategy didn't benefit oxygenation as we potentially would have liked to, and had negative consequences. And in fact, this patient population, as demonstrated here, would respond greatly to fluid. So the first one is a pre-fluid bolus. The LVOT VTI is 18 in this case, and immediately post-fluid bolus, it increases to 25.2. So a very fluid responsive state, and mechanisms of which are complicated, but overall, within the first 2 weeks, because we saw quite a high incidence of AKI, we changed our protocol based on what we were seeing, and the rates of AKI dropped after that. But hang on a second, let's go back to the heart. Overall, every time we echo them, the right ventricle looks a bit big, and overall, every single report comes back a moderately dilated RV and a normal or mildly elevated TRV max. And I think to understand this, we've got to really think about what happens in normal sepsis. Let's talk about gram-negative sepsis because of renal tract infection. So you get a high cardiac output state with vasodilation, and everything looks hyperdynamic. The afterload, systemic vascular resistance is low, but also the pulmonary vascular resistance is low. And therefore, the left ventricle looks like a hero. Yeah, it looks impressive, hyperdynamic, coping fine, high cardiac output, because the afterload is low, and that's fine. But actually, 2 days later, once you've volume resuscitated the patient and corrected some of the low afterload issues, the left ventricle can sometimes look less impressive, look less hyperdynamic, maybe even inappropriately less impressive, less systolic activity than you would expect. So let's extrapolate with the right ventricle. In normal sepsis, gram-negative systemic sepsis, pulmonary vascular resistance would be low as well. But in this case, we have a very hyperinflammatory condition, which is, it's originating from the lungs. So you get hypoxic vasoconstriction and worsening lung consolidation. And that actually normalizes in the first instance the pulmonary vascular resistance, and then later on increases it. And therefore, any negative inotropic effects of the inflammatory milieu that are systemic, that are become apparent much earlier on the right ventricle, because the systemic vascular resistance, the pulmonary vascular resistance, which it's pumping against, is now normal or even raised. And therefore, the right ventricle starts to struggle much earlier on in the disease process. And again, I'm sure my colleagues out there who have echoed these patients will agree, it is a matter, almost all patients on a ventilator had a dilated RV. Now, when you start looking at indices of systolic function, on the whole, especially early on, they were preserved. Global longitudinal strain, TAPSE, S prime, fractional area change were all within normal or even supernormal limits. And therefore, when you report these patients, their systolic function is normal. Now, I think it's important to understand that our normal values that we know and learn are not in hyperdynamic septic patients of this magnitude. So therefore, even though they report as normal, it may be inappropriately low given the situation, and maybe not in keeping with the same level of hyperdynamic situation that the LV is demonstrating because of the higher afterload. So what do we do with this information? Well, I think it's important to realize that flow for the pulmonary circulation is all to do with the balance in the force. Force generated by the RV against resistance in the pulmonary circulation results in flow. And the resistance is determined by your ventilatory management, hypoxic vasoconstriction, worsening parenchymal disease, and microthrombotic disease as well. And actually, all of these things, even in a hyper-inflammatory state, would normalize in the first instance and then increase the pulmonary vascular resistance, which would explain the tricuspid regurgitation. And because there probably is a negative inotropic effect on both ventricles, but now the vascular resistance the right ventricle is pumping against is normal or high, it unmasks the fact that the right ventricle struggles early on in the disease. So I think that is an important thing to realize when dealing with this condition. And despite our best management, the greatest teacher failure is. And the right ventricle progresses with, first of all, moderate dilation with preserved function, increasing dilation with an increase in your TRV max as your lung disease worsens, a reduction in your systolic function, or borderline normal, which in context is reduced. And then you get severe dilation with pressure effects on the LV, and then there's a PE. And the last two, I think the lines are blurred. And of course, it was Yoda that said the greatest teacher failure is. So despite all your best efforts, you're scanning your patient repeatedly because that's the way it's useful. If the doctor in charge and who has continuity does repeated measurements, and the right ventricle is ballooning out. It's now severely dilated, and the measurements of function are now borderline. So your TRV max is creeping up to about 3 meters per second. Your S prime is now borderline at 10 or 11, and your TAPC is borderline at 17 millimeters. So all these things, given the fact that the left ventricle is hyperdynamic, it means the right ventricle is severely impaired, not just borderline. And this is the left ventricle, and taken in isolation, the left ventricle appears very fluid responsive. The E wave velocities are high, E over A is normal, and your tissue Doppler is also hyperdynamic. So in isolation, the left ventricle would tolerate more volume and maybe even benefit from it. But obviously, the right ventricle being dilated and poorly functioning would be a contraindication to giving further fluid. So you're getting a bit stuck. So what are your options? Well, you can play a little bit with your PEEP. You can try and increase your mean arterial pressure as a surrogate to try and increase your right coronary perfusion pressure to try and improve right ventricular systolic function. It's a bit of a long shot. You could switch to vasopressin to try and spare any increase in your pulmonary vascular tone that noradrenaline at high dose may be contributing. You can add in an inotrope, but I think that's a pretty dangerous strategy when your left ventricle is so hyperdynamic. You can try and diurese to improve right ventricular function, but again, overall, your fluid balance is probably significantly negative, so that's a very dangerous strategy as well. You can prone to try and improve lung recruitment and therefore reduce pulmonary pressures, and you can try pulmonary vasodilatory therapy. The first thing most people could do is play with your PEEP. And it's like trying to lift your elephant that's sitting on your chest up and down a little bit, see what happens. And in a minority of patients, this can be effective. This was one such patient who ended up being intubated overnight, being put on a PEEP of 15 because that was the PEEP ladder, given how much oxygen he required. And he ended up on 0.2 of NORAD. And over the course of a few hours, I reduced his PEEP down from 12 and then to 8. And I think you can see how the right ventricle shrinks over this time. And by the end of this maneuver, he was down to 0.08 of noradrenaline, and his oxygenation was down, his FiO2 is down to 50%. So definitely a case of overdistension causing acute cor pulmonale in the early phase. But overall, if you consider the right ventricle a camel, and there are no other parallels other than what I'm about to say, is that it suffers because multiple different things affect it. So we've already talked about how hypercapnia and hypoxia can cause RV failure. The lung parenchymal disease itself can do it, and your ventilator strategy with high PEEP, especially if you follow the PEEP ladder in early COVID can really cause overdistension and acute cor pulmonale. Your vasopressor choice may have an effect. And we've already talked about how the inflammatory milieu can actually affect the right ventricular myocardium, resulting in less force generation of the right ventricle, in addition to higher afterload by the lung disease. And then you have your PEs. And we're used to thinking of PE as being a big problem, a big PE being a problem as an indication for thrombolysis. But in this case, it may be that a small PE or multiple small PEs may be the straw that broke the camel's back, hence the camel in this slide. So despite all your best treatments and everything that's going not very well, you do a repeat echo because suddenly the noradrenalines are not 0.4. And this is what you see. And it's a pretty dismal situation because the right ventricle is very, very prominent. And more importantly, is now pushing the septum into the left ventricular cavity. So it's preventing the left ventricular filling and impeding flow out of the left ventricular outflow tract. Yeah, so that's a very disturbing situation. You can see here, very, very clear septal flattening and a very impressive right ventricle indeed. And doing some measurements, the TRV max is now at 3 meters per second. The IVC is completely fixed and dilated, despite being fully mechanically ventilated at 8 mils per kilo. And this is the flow out of the left ventricular outflow tract. And you can see it's slow rising, dagger shaped, and reaches 1 meter per second. So good evidence that there is now left ventricular outflow tract obstruction as a result of right ventricular dilatation. So this is the kind of patient that has a sudden PEA arrest and is then unretrievable. If you see a floating thrombus, it makes your decision a bit easier about thrombolysis, especially given all the evidence base to say thrombolize a massive PE, a submassive PE is a bit trickier, and overall the risk-benefit analysis doesn't always favor thrombolizing a submassive. Now, I think we have to readjust that mentality because PEs in this case are additive, don't exist in isolation. But in this case, we found the right ventricular thrombus, and 2 days later after thrombolysis it had gone, and you can see the right ventricle is also improved in both size and function. And in this case, the right ventricle was dilated, the patient was on 0.5 of noradrenaline, and you can see very, very clearly a saddle thrombus right there and there. Sadly, we thrombolized this patient, but he died a few hours later. And thrombolysis can help the select few. This is a patient who, again, suddenly hit a noradrenaline value of 0.25, then 0.35. His IVC was fixed. His TRV max was 3 meters per second. And again, function-wise, I beg your pardon, size-wise, the RV is now severely dilated, and function-wise, it's borderline. But the LV is hyperdynamic, and therefore the RV is out of context. And we thrombolyze this patient, and even though the TRV max hasn't changed very much, the TAPC has changed, the S prime has changed, the IVC now shows variability, and you can see here the size of the RV has gone down. And most importantly, the NORAD has gone from 0.4 to 0.04 in the course of 48 hours. So a successful thrombolysis in this case. Moving away from the RV, the LV is also important. And myocarditis secondary to COVID is probably quite rare. We didn't see very many of them in our institution. I think what's much more common is a stress cardiomyopathy. And when I say stress, I mean it could be multiple stressors, so adrenergic or septic or metabolic, whatever the mechanisms, they present in a similar fashion. Don't forget that very high dose sedation can also contribute significantly to negative inotropy. And there's existing heart disease, plus the physiological conditions that we've already talked about are a bad combination. And I'll show you one case. And don't forget that being hypermetabolic means your oxygen requirement and therefore your oxygen delivery is required to be higher. And therefore any existing coronary artery disease could result in regional wall motion abnormalities. So don't forget to look for those. This is one case that was diagnosed with myocarditis. So you can see that very quickly he ended up on a abnormal amount of noradrenaline for early COVID. So we got used to having patients on 0.05, 0.1 of noradrenaline. This patient ended up pretty much straight away on 0.35 of noradrenaline. He bought himself an early echo, and you can see how poorly his heart is functioning. Apologies, I don't know why that one isn't playing. And you can tell that it's an acute situation because actually, if you look at his mitral inflow, E over A is pretty much normal. These velocities are normal, 0.6 meters per second, absolutely normal, yeah? So that pattern is fine. Even the E prime is not massively reduced, but your VTI is catastrophically low at 9, okay? So a classic acute cardiomyopathy because of something acute like myocarditis or a stress cardiomyopathy. And actually in this case, Echo helped us titrate his therapy, which in this case was dobutamine. Here we started off from on 2.5 of dobutamine. We managed to get his VTI to 11.5. This one was on 5 of dobutamine. His VTI is now 13.7. This one on 7.5 of dobutamine. His VTI is now 14. And this one on 10 of dobutamine. His VTI is now 16. On 12.5 of dobutamine, his VTI went down to 14 again. So we assumed that the optimum dose for this gentleman at this time was 10 mics of dobutamine, and that's why we left him at. And you can see this effect very nicely in the short axis of the left ventricle as the systolic function improves. And funnily enough, he went for ECMO after this failed, after 2 or 3 days, and he came back and his heart was much better. He spent a long time weaning, and it's definitely not normal, but definitely better than what it was. Another case, this time the left ventricle looks abnormal. There's apical dilatation, and there is akinesia at the apex and the mid levels of the left ventricle with relative basal sparing. So this is a typical appearance for an acute stress cardiomyopathy. And again, it suggests acute rather than a chronic situation because here your E over A is relatively normal velocities, and your E prime is not catastrophic. So suggesting again of acute cardiomyopathy. And 2 weeks later, with good supportive treatment, this time didn't need ECMO, basically back to normal. Now, this patient presented with COVID, got intubated, hypertensive diabetic lady, and every time she was prone, she nearly arrested. So believe it or not, they tried to prone her 3 times before they gave up, and then they requested an echo. And I think it's clear to see why she was arresting or nearly arresting every time she was prone. This lady's clearly got significant hypertensive heart disease with this very prominent septal knuckle that seems to be occluding her left ventricular outflow tract, okay? And you can see here the turbulent flow through the left ventricular outflow tract, a little bit of AR as well. And here the velocities for the mid cavity were approaching 4 meters per second, so pretty catastrophically high. And you know, these patients are very, very sensitive to changes in preload. So being hyperdynamic and having a low systemic vascular resistance and having a low preload is a combination for disaster in these patients. And every time we proned her, we presumably reduced her preload even further, and she nearly arrested. So by knowing what her pathology was, we were able to manage her situation better. And let me just talk a little bit about obstructive shock, because obstructive shock in this context is not just pulmonary embolism. You can actually induce it with your ventilation.
We're running a little bit over. So.
Yes, I have 2 more slides. I'm sorry. Is that okay? Oh. Is that okay? 2 more slides?
Yeah, that's fine.
You can induce obstructive shock with your ventilation, and also disease processes can cause obstructive shock. And this is a case of a tension hemothorax, and you can see vast quantities of blood within the chest, and this is the hematoma, expanding hematoma that's obstructing the left ventricle. So a very interesting case. Now, so suddenly your differential diagnosis of shock is far more complicated than it initially appeared, and therefore, thank God we don't have to think about spinal shock, and therefore the therapeutic options are also much, much more complicated. And if you're trying to answer this question in an exam, how would you manage a cardiovascularly unstable patient with COVID-19? What is the best treatment option with these options? It would be impossible. And I think the important take-home message is that you can't answer it unless you perform an echo and understand the disease process and understand your therapeutic options. I was going to make the point that pre-existing heart disease and acute heart disease in COVID is relatively common. But overall, echo in this disease can aid with diagnosis because shock is multifactorial and protocolized management is very difficult for these patients. You can titrate your therapy, you can monitor for progress and response to treatment, and you can initiate new therapy. And overall, he must have been an echocardiographer with an interest in clinical medicine, because he is right that to rebalance the force, you need to understand the disease process and understand what your treatments can achieve. And I'd like to say thank you to the POCUS team at St. George's Hospital for doing all the hard work. I'm sorry I ran over.
No problem. Thank you very much, Johnny. I'd like to move on now and ask my colleague and friend, Dr. Hazim Lashin from Barts Hospital, and he's going to talk about the right ventricle and COVID-19 respiratory failure. Hazim, over to you.
Can you hear me? Hello?
Yes, we can hear you.
Good afternoon, everyone. My name is Hazim. I work as a consultant in critical care medicine with interest in echocardiography, and I work at Barts Heart Centre in London. So I was asked to talk to you today about the right ventricle in COVID/ARDS, and my colleague Jonathan Aaron, who spoke before me, stole my thunder, but there we go. The objective of this talk was to quickly go over the RV in COVID literature, also review the pathophysiology of RV dysfunction ARDS, assessment of RV by echocardiography, and if time permits, we'll go through up to three case studies. So many studies have come out now looking at right ventricular impairment in COVID-19 patients. The studies so far that I've seen have not been exclusive to ICU patients, but they looked at all hospitalized patients. The prevalence of dilatation of the right ventricle is up to 31%, systolic impairment and dilatation up to 39%. There has been also a case series in the New England Journal of Medicine where they have shown that there is high peer pressure with RV impairment in COVID-19. How does COVID-19 affect the right ventricle? In many ways, one of them is hypoxia, and hypoxia has been shown to have a direct effect on the right ventricular contractility. Also, pulmonary vascular dysfunction, which is a constellation of problems affecting the pulmonary vascular bed. One of them is vasoconstriction, which is mediated by hypoxia itself and also by inflammatory mediators, microvascular thrombi, endothelial damage, which is part of the pathophysiology of ARDS/COVID, also vascular remodeling because of inflammation and decreased lung volume, causing compression of the microvasculature in the lungs, resulting in pulmonary vascular dysfunction. All these factors will result in increased pulmonary vascular resistance, which with time, as my colleague has mentioned previously, will lead to increase in pulmonary artery pressure. The other mechanisms that may contribute to the effect of ARDS/COVID on the RV is the therapeutic interventions that we perform. So mechanical ventilation can have a very deleterious effect on the right ventricle. So high PEEP reduces RV preload by reducing venous return, and if this PEEP has been titrated up to the point that it goes above the CVP, it may block the venous return altogether and result in cardiac arrest. Also, raising the PEEP will rise the peak airway pressure, and that will cause compression of pulmonary vessels, resulting in increased pulmonary vascular resistance. And with time, this continues to go up and up and up, resulting in significant rise in pulmonary vascular resistance and the RV afterload, which with time doesn't have to be very long, can result in RV dysfunction and then failure. Also cardiovascular interventions can affect the right ventricle. As we know, excess fluid resuscitation will increase RV preload, and the RV, as we all know, is a very thin structure, and this increase in the preload can result in RV dilatation and impairment. Also, excessive diuresis can increase RV afterload by reducing the caliber of the pulmonary vessels, which the small vessels in the lungs, which will result in increased afterload. Noradrenaline, as my colleague has previously said as well, can result in pulmonary vasoconstriction, adding to the RV afterload, and all this give us the picture that we see of the RV dysfunction in COVID/ARDS. So the clinical expression of this starts with a mild increase in the pulmonary artery pressure, which increases with time to reach severe pulmonary hypertension, acute cor pulmonale, RV failure, and multi-organ dysfunction, which we see often in these patients and sometimes can be fatal. And I find this definition of acute cor pulmonale very helpful, and it's very POCUS orientated and can be performed and can be found and reached with basic echocardiography, similar to focus intensive care echocardiography that we have in the UK. So acute cor pulmonale is defined as obviously acute change in the right ventricular dilatation more than 0.6 of the area of the left ventricle, and paradoxical septal motion in systole in parasternal short axis view. And as you can see, these parameters can be obtained by very basic echocardiography without any advanced techniques. Advanced techniques will help, but I think if this would be sufficient for the management of most, if not all, of the acute cor pulmonale. The pre-COVID, there was a study that was performed in ARDS with protective lung ventilation, and the reference is at the bottom. It's up to 22% of patients with ARDS will have acute cor pulmonale. Then we go into the RV assessment by echocardiography. As we said, the RV, first we talk about the RV anatomy and how it contracts. The fibers of the RV are arranged longitudinally, and longitudinal contraction of the RV, as we all know, is the main driver of the RV RV output. There's also radial and inward contraction, which is mediated by the fibers that are going across, and they are also mediated by the contraction of the LV pulling on these fibers, and that's what gives the radial inward motion of the RV free wall. And also there is a bulging motion of the interventricular septum that also adds to the RV output. So it was thought that each of these components of the RV contraction are equal in contribution to the ejection fraction of the RV. Then the RV size. So end diastolic area of more than 0.6 of the LV diastolic area. And here I have two examples. Hopefully they will start work soon, where you can see on the left hand side a normal echo, and you can see that just looking at it, the RV area is smaller than the LV. And then on the right side, this is a case of a dilated LV, albeit with what seems to be a reasonable systolic function. I'll leave that for a second, just for people to appreciate the difference between these two. It's not always this obvious, and there is a lot of subtleties in this, which we'll talk about in a second. RV systolic function, as my previous colleague has alluded to, can be assessed by many techniques. The first technique is just looking at the RV and getting used to looking at it, both in normal individuals and in disease. And that usually would be in POCUS anyway, in basic echocardiography, would be the mode of assessing RV function. But for more advanced techniques, tricuspid annular plane systolic excursion is the most commonly used and the most commonly researched mode of diagnosis of RV dysfunction or assessment of the RV function. And it measures the distance that the tricuspid annular plane moves in systole by a technique called M-mode. Normal is anything up to 17 millimeters. Another technique, which is the RVS prime by tissue Doppler, which measures the speed at which the tricuspid annular plane moves in systole, and the normal is above 9 centimeters per second. The first two techniques mainly measure the longitudinal function of the RV, but doesn't incorporate the rest. The fractional area change is another technique which measures the difference in percentage between the right ventricular end diastolic area and right ventricular end systolic area. Normal is around 35%, and this is supposed to incorporate more of the radial function, the contribution of the interventricular septum to the RV function, as well as the longitudinal function of the RV itself. But the problem with it that it's a lot of inter and intra observer variability in it, making it less reliable. Then the newer techniques, which is the 3D echocardiography, which assesses the whole of the RV, not just the interventricular septum and the free wall, but also incorporates the right ventricular outflow tract. But this is obviously quite difficult to do in patients on mechanical ventilation because it requires a really very good image quality. And also right ventricular strain, which my colleague has alluded to, which measures the longitudinal change in the length of each segment of the right ventricle and the interventricular septum, or only the right ventricular free wall. And normal is around -20%, which means that basically the RV will shorten by 20% in systole. Then I've got a case, a COVID-19 patients who have developed respiratory failure requiring VV ECMO and very quickly deteriorated overnight with hemodynamic collapse, requiring emergency VA ECMO on top of his VV, so he ended up on VAV ECMO. An echo was performed, and this is a parasternal long axis view. I hope it projects reasonably well. As you can see there, in the right ventricle on the top is dilated and is not moving at all compared to the LV. And the LV is hyperdynamic again, which echoes what the previous speaker has been saying. And this is a parasternal short axis view, which again shows that the RV is dilated and the interventricular septum flattens in systole, which is an indirect marker of raised right ventricular pressure. And following these two pictures, we can say that this patient has got acute coma pulmonale. We don't need anything else to tell us that the patient's right ventricle function is significantly compromised. This is a 4-chamber view of the same patient. Unfortunately, it was quite poor, but this is what we managed to get. As you can see there, the right ventricle is significantly dilated, and it looks bigger than the LV, and the interventricular septum is bouncing, which is again a marker of raised right ventricular pressure. When the right ventricular dilatation exceeds the size of the LV, this would be classed as severe acute coma pulmonale. And this is a simple measurement of the tricuspid regurg maximum velocity, which is more than 4 meters per second, which equates to 67 millimeters of mercury plus right atrial pressure. So at least this gentleman will have a right sided pressure of more than 17 millimeters of mercury, which is way too high, and this is the cause for his hemodynamic compromise. Then we have a second patient, which is a COVID-19 patient, again with respiratory failure, severe respiratory failure requiring ECMO. Then this gentleman became hemodynamically unstable. And again, this is his parasternal long axis view. As you can see here, the right ventricle compared to the left ventricle is dilated, not as much as the previous case, but remains dilated, and perhaps the function is slightly better in this view. On short axis view, as you can see there is a flattening of the interventricular septum, making this a acute copulmonale and denoting raised right-sided pressures, even if we can't measure it. And this is a four-chamber view of the same patient. Again, the right ventricle is dilated compared to the left, and the interventricular septum is bouncing, which is again a measure of high right-sided pressure. This is the TAPSE that was performed by M-mode on this patient, which has shown that it is significantly compromised. So as we said, the tricuspid annular plane systolic excursion anything above 17 millimeters, and in this gentleman it was less than 1 centimeter, i.e. 10 millimeters, which is significantly impaired. And this is a very interesting strain analysis of the right ventricle, looking at the deformation of both the interventricular septum and the right ventricular free wall. And as you can see in the top left-hand corner, the mapping of the RV. So the red, blue, and pink parts are the right ventricular free wall, and the green, bright blue, and yellow are the interventricular septum. And the strain maps on the right-hand side, the curves, show that the interventricular septum segments are contracting much better than the free wall, and also there's post-systolic shortening and lengthening of the right ventricular free wall. So this is just to demonstrate the various techniques that we can use for assessment of the RV and how deep we can go. But as I mentioned, acute copulmonale does not require any of this to be diagnosed. 1 month later, this patient was still on the ICU, ventilated and weaning very slowly on pressure support ventilation. And if you look at the bottom of this echo image, you can see that there is the ECG trace and also the respiratory trace. And when this patient was in expiration, his septum looked normal, and when he took a breath with pressure support from the ventilator, the septum flattens, which demonstrates very nicely the effect of positive pressure ventilation on the RV and NV, in fact. Then we have a third case, which is again a COVID-19 patient with respiratory failure on mechanical ventilation, slowly becoming hemodynamically unstable with rising requirements of cardiovascular support to maintain his blood pressure and organ perfusion. So this was his four-chamber view. I just wanted to have a look at it for a second and think, how is this ventricle dilated? Is this systolic function good or impaired? So to me, this right ventricle does not look dilated particularly. The left ventricle looks okay, and the longitudinal function seems fine. And actually, the TAPSE was bang on the border of normal, which was 17 millimeters. And parasternal long axis view showed that he has got septal flattening. Then a fractional area change was performed because it wasn't clear for these patients, for the doctors who were looking after this patient, how if the right ventricular function was good or impaired, and that has revealed that his fractional area change was 27%. So a bit impaired, compared to the normal, which is considered to be 35%. So, sorry, so what I was getting at with this case is that the right ventricular impairment can be very subtle and difficult to detect. But if someone is hemodynamically unstable, you would expect that the right ventricle will be hyperdynamic, as the previous speaker has mentioned. But if it is borderline or just mildly impaired, this is probably much worse than we think, particularly in someone who is got extensive lung disease. So in summary, right ventricular dysfunction is common in COVID/ARDS. Many factors contribute to COVID-associated right ventricular dysfunction. Right ventricular dysfunction is usually associated with raised pulmonary artery pressure. Echocardiography is the main assessment tool, and right ventricular changes on echocardiography can be subtle and difficult to detect. Thank you, and over to Steve.
Thank you, Hazim. As with the other sessions, we'll take questions at the end of the session. And the last speaker that I'd like to introduce is Dr. Philippe Rolla. He is a self-confessed POCUS addict and chief of ICU at Santa Cabrini in Montreal. And he's here today to talk about venous congestion and vexus. Okay, Philippe, over to you.
Hi, everybody. I'm just going to try to get the tech going here. I seem to have lost control of my computer.
We can see your screen, Philippe.
You cannot see my screen?
Yeah, we can. Yes, we can.
I just seem to not have any. Okay, I've got something just came back. Okay, so let me back on this.
Yeah, great.
All right. Okay, so hi everybody, and thanks so much for inviting me on this this super panel. I've been learning a bunch so far today. And I'm really glad to be here. And I'm going to talk about something that's a lot less exciting, I think, than what's been spoken about so far. But I think it's going to tie in a little bit to some of the previous discussions of Jonathan and Hazim. All right, so today I'm going to talk about venous congestion and vexus and embracing the dark side of POCUS. So I particularly appreciate Jonathan's references to some characters, which we'll link to soon enough. Oops. Okay. Not sure why that switched to that. All right. So just quickly, my affiliations, they can be saved for later. Anyone can take a look at them. Teaching is awesome. Love the foam concept. And definitely, as Carlos said, I'm a POCUS addict, and I think it should be infiltrated into every fiber of clinical evaluation that we do, or just about. Here's my disclosures. I do teach and occasionally consult. And so let's hop right into it. This is essentially was my conception of congestion from starting practice around 2000 to, let's say, about 2015. Let's look for lung congestion, added in some B lines, and look at the peripheral stuff. And that's pretty much was my extent of my congestive assessment. Sometime around 2015, Andre Deneau from the Institute of Cardiology in Montreal started to tell me, you've got to start looking at the portal vein. The portal vein? What do I need to look at the portal vein for? Because somehow congestion occurs, and when it shows up in the portal vein, things are not good. So nowadays, my congestion assessment looks a little bit more like this, with a heavy load of Doppler, and of course what I used to do before, which does certainly remain important. But now there's the whole aspect of splanchnic congestion, which affects a lot of organs and does have a huge clinical impact. on patients' outcomes and courses, and those of us doing this can see this. Now, what is this about? Why? Why do we do this? Well, I think for a long time, the focus has been and still is on the arterial side. That's the fun side. That's the cool side. You know, and MAP is the main goal. Except that we seem to forget the concept that organ perfusion pressure, and even when you look at how you measure that, it's always MAP. The reality is that the organ perfusion pressure is not exactly the MAP, but rather the pressure differential across the capillary, which really reflects the precapillary arteriolar pressure, which is a lot lower than the mean arterial pressure. And on the other side is your venous pressure. So while it's easy, if you're thinking in the numbers of MAPs in the 60s and 70s and 80s, it's easy to disregard a CVP that goes to 5, 10, or even 15. But when you look at the actual pressures that the precapillary arterioles have, which is, as we can see in this nice graph here, substantially lower, maybe as low as 40, all of a sudden a CVP of 15 or imagine 20 is severely impairing our organ perfusion pressure. So this is why the dark side, the venous side circulation does need some attention. So how can we look at this? So splanchnic venous Doppler, the main things that we'll look at is the hepatic vein Doppler. So on the left side, you've got normals, and as you're going towards your right, you're getting more and more abnormal. And essentially, if you think about it, to just click into something, you know, your hepatic vein Doppler, which is right, the entry point into your right atrium, essentially is essentially your CVP tracing. And you can correlate that, you know, which has been named A, S, and D as the waves to your ACXVY, essentially, and then that can help click things. Now, the portal vein is separated from that by a whole capillary network. And of course, the intrarenal venous Doppler is a fair bit lower. So the idea really behind it is that normally pressure waves don't travel that far down because they get dampened by capillary networks, by distance, by the compliance of the venous vessel, so they don't appear. However, if the pressure does get high enough, and I'm just going to skip through this one, it actually goes across and is able, the retrograde pulsatile pressure from the right atrium goes across and becomes visible all the way up into the portal vein, the hepatic vein, and even down to the kidney. So we can start to see, if you look at the middle section of the mild or the mild abnormality, where the S and Ds do appear essentially on the renal side, and you lose the positive deflections because it's lost in the arterial tracing, then essentially the pressure is transmitted all the way down there, and at this point is impairing the venous outflow and causing, if we're talking about the kidneys, causing renosarca. And here we're not even really able to, well, at least not yet, look at the gut venous effluents. Obviously, they all end up in the portal side, but even more proximal, because this will cause not just renal dysfunction, but gut dysfunction. So this is an important concept, that looking at the venous pressures, but not only the pressures, because we can just look at the CVP and estimate, but the actual physiology at the organ level can tell you how much the congestion is really affecting the splanchnic organs. So we do know that if you look at both sides, if you have a low cardiac output, you know, you're going to have, you know, troubles at the levels of the tissues, but the elevated CVP as well will give you that just as much. There's actually old studies from the 50s that displayed this, where they were doing just renal vein partial ligations, and that was just as bad as decreasing the cardiac output. So it's important to look at both sides of circulation. This is not new. This is not new data. There's several papers that have never really gained a lot of traction or attention from clinicians, and I think largely because you know, in the early 2000s and even some in the 90s, there really was no POCUS going on. So the bedside clinicians would have had essentially no access to this, and the people who had the skills to do it were generally the sonographers or the people in relatively specialized clinical aspects, and not taking care of your day-to-day acutely ill patients. So now we've got the patients and we've got the clinicians with the skills to do this. So it's becoming really interesting. Just quickly, this is a great little graph that's showing the progression of congestion across the splanchnic organs. And like I said, there's been a number of papers out, but really the bulk of the work here has been done by André Deneau and William Beaubien-Souligny's groups, who they have a captive set of patients that are post-op cardiac patients, and they showed clearly a strong association between the presence of splanchnic congestion, portal vein pulsatility, and post-op renal dysfunction. And even in terms of personal communication, they have shown associations with the time to extubation, post-op delirium and confusion, which, obviously we tend to forget about it, but the brain, even outside of trauma and infection, is a perfect setup for compartment syndrome. So across all organs on the splanchnic side and even the brain side, this does happen. So recently, the term of VEXIS has come about, and we put this together. It was published a few months ago as essentially a way to put everything together and make for a more robust venous congestion assessment. And so we tied in all the venous Doppler parameters in order to build something that could be used clinically at the bedside and could avoid some of the pitfalls of false positive findings, which can occur if you're just looking at one isolated value. But putting them all together makes it a little bit more solid. So here's a nice little video infographic here showing the progression of VEXIS. So the cornerstone of VEXIS is looking at the IVC. And here the images are in long axis. I will say that my far preferred way to look at the IVC is in short axis across the board. Why? Because the IVC is not a cylinder. For those who look at it enough, as it collapses, it becomes an ellipse, and the angle of that ellipse can change depending on the patients. So the long axis has some pitfalls of sometimes being able to fool you and looking distended and fixed when it actually isn't, if the ellipse is horizontal enough. But anyhow, the studies were done using traditional long axis. And we can see that as the IVC gets full, the pressure gets passed down and becomes visible and worsens at the levels of the hepatic vein, portal vein, intrarenal vein. So our VEXIS classification is that if you have a fixed and plethoric IVC that is associated with severe abnormalities, so a portal vein pulsatility of more than 50%, and a very discontinuous, and in this case, monophasic venous signal at the level of the kidneys, then you've got the highest level of VEXIS, VEXIS 3, which was associated with a several-fold increase in the risk of AKI in these postoperative cardiac patients, and is currently being studied. We have a couple of other articles that are out submitted and showing, in more general ICU populations, again, an association with AKI in terms of fluid resuscitation. So here's a quick one that I will try to play. All right, so here's the demo, as many people have been asking for, of the VEXIS score on a patient. So here I'm going to go in short axis for the IVC, and here we are. We can see that he's got a nice plethoric IVC, and I'm going to pan up and down throughout as much of the hepatic segment as I can see, and we can see that it's fairly circular, has minimal variation. And there we go. So that is right there a grade 4 IVC. From right here, I'm going to pick hepatic vein, put color on it, and we can see that this is kind of a
police siren sign. We've got lots of red, and instead of the nice little red, blue, blue, we've got lots of red and blue all the time. Take that off, put a pulse on it. Remember, you have to get your venous settings on, just the scale a bit. And we can see right there, we've got a markedly abnormal scan with a above the baseline S wave. So this is a grade 2 venous tracing. So we're already headed towards a high VEXUS score. All right, next I'll show you 2 ways to do the portal vein. The first is the lazy way, which is right here, and oftentimes you can get it. Now note the portal vein has a nice white hyperechoic walls to it. And here I'm not getting the best view. And I'm also, my scale is a bit too high. And we can see that we've got a pulsatile view here. Again, I'm staying here in the subxiphoid area. So this is the lazy way to do it. If I'm going to be a little bit better, I'm going to actually take the probe and go out laterally. I need some gel. And go out laterally, and we can see that we get actually a better angle on the portal vein. There's a little less respiratory motion. Again, I'll put my pulse wave on it. Actually here, for fun, we'll put the color on it, and we'll see that even on color, there you go, it's clearly a pulsating portal vein. Here we've got a tracing that's actually got both arterial and venous. I'll adjust it a little bit to focus more on the venous. So we've got a nice superimposed images here. We've got the nice venous tracing in a brighter white, and we can see is essentially 100% pulsatile. So already we've got grade 2 in portal, grade 2 in hepatic, and a fixed IVC. So we're already a VEXUS 3, but just for fun, we'll see what we can get for renal images here. Intrarenal venous Doppler. So here I'm going a little laterally. I have a little rotation of the probe that is counterclockwise to my hand. I try to get a nice long axis of the kidney, and I put some color on it, try to aim. And I'm aiming for an arcuate vessel or an interlobar. I've got a couple of ones that look decent here. I'm going to drop my depth here to maximize my ultrasound power. We'll see what we can get from these areas. This is the hardest part of the exam. So we can see here we've got, it's actually a nice tracing you don't often get to see. Pretty much an isolated venous trace. We've got a little bit of arterial trace in the background, but basically we have an interrupted, what we typically call monophasic, because we usually don't get to see the venous flow above the baseline, but in this case we do. So this is really analogous to your hepatic vein tracing with a positive deflection in what's the S wave equivalent, which we normally don't see, and then a D wave equivalent, so which is the systolic, the diastolic portion, obviously, of the flow. So again, markers of severe congestion. So this patient here is indeed a VEXUS 3 level of venous congestion, and I'm going to pursue with this fellow's D congestion.
All right, so I'll try to wrap up quickly, but that gave, I think, everyone an idea of how the VEXUS is done. So how can we use it in COVID? So essentially, when do I use VEXUS? Pretty commonly. Any kind of resuscitation during rounds, anytime dealing with AKI or CHF, and particularly this really links to right-sided dysfunction, whether primary, secondary, or just due to overvigorous resuscitation. So I'm just going to share a quick thing about when I'm talking about fluid resuscitation. My 3 most important questions that I go through is, the first one is, do I think my patient needs fluid? Then I'm going to ask myself, is my patient volume tolerant? And that's where there are many things I look at for volume tolerance, but VEXUS is clearly one of them. And the last, and it's not a typo that the third point is small. It's because to me, it's the least important question. Is my patient volume responsive? And it's not that that I think it's unimportant, is that I think there's no point even doing it unless I've answered yes to the first two questions. And most of the time, I find that I rarely actually have to look for it because I'm rarely faced with a patient that I feel needs fluid and that is volume tolerant, especially in the setting of acute respiratory failure. They may be sometimes, but I think the question really does need to be asked in a very strong way. And I just put that nugget of gold there because I think that a lot of people have really gone for volume responsiveness as being the gold, but I would argue that it's more like this pyrite. It's more like the fool's gold, and that it's not as valuable as we think or have been thinking. So how do I use it? As a fluid stop point. If I have a VEXUS 1, which is already a dilated fixed plethoric IVC, that is a hard fluid stop point. I don't even need to go to the rest to decide whether or not I'm going to stop giving fluids. If I have a VEXUS 1, I'm stopping fluids. If I have a VEXUS 2 or 3, I may strongly consider to U-turn on the fluids and pull some fluids off and unload the RV with diuretics or renal replacement therapy or something like that. So just that said, I think we're going to have a lot more data on this coming out, but I think it's something that POCUS users out there should probably start looking at and getting your skills looking at the splanchnic venous Doppler side, because I think more and more we'll find that it is really important. So I think the important is to keep calm and do come to the dark side of the circulation. Thanks very much. Any questions? Here's how you can join.
Great, thank you very much. So I have some questions for all of our panelists actually. So if I could start with Dr. Roller. Question, how much training is required before you can be considered competent to perform an VEXUS study?
I think it really depends on your baseline level of POCUS skill. I think I've taken, people who are already high level of skill, and I think it takes them just 5 minutes of, scanning, and then afterwards they need to go on and put in their time to do it. But I don't think it's really very complex. The one that is harder and just requires practice, and sometimes you just can't get it, is the intrarenal venous Doppler, because those are very small vessels. Particularly if you have someone who's short of breath, it can be tough to acquire a quality enough image that you can be sure to interpret. And in a way, this is why we built the VEXUS like that, because even if you can't get all the elements, if you've got that 2 out of 3, so far it's panned out that that's good enough to signify that there's organotoxic levels of congestion.
Okay, thank you. Question for Johnny and Hazem. So one of the attendees has asked about APRV. Some commentators have championed it in COVID, but obviously it leads to high mean airway pressures. How do you think it interacts with RV dysfunction? Johnny, perhaps if you want to take that first.
Yeah, sure. Yeah, so I'm an advocate of APRV. I think, like with all things, I think it has to be patient specific. In early COVID, one of the presenting features was severe hypoxia, but very compliant. And clearly there's very little consolidation at that point, very little recruitment, and therefore I think APRV loses some of its value. I think it's a technique where it's actually a very good recruitment maneuver, and by recruitment maneuver I mean something lasting hours to days rather than 40 for 40. So yes, for me, I often would echo someone on APRV and identify RV dilatation. And actually, in early COVID, the benefit of very high mean airway pressures, it didn't have any correlation with oxygenation. So I would take them off APRV, put them on something more conventional with lower mean airway pressures. The RV may improve at that early stage, and actually often you're over-distending the lung parenchyma, reducing pulmonary blood flow, and your oxygenation improves, your oxygen delivery requirement decreases. So on the other hand, I think there's later disease where there is consolidation and parenchymal disease where APRV can be beneficial.
Okay, thank you. Last question, Hazem, if you're still there.
Yes, here.
So how reliable is RV free wall strain analysis?
Well, it's a $1 million question. I think it is as reliable as the person who's doing it. So people who have had extensive training and are used to doing it, they can get very good results. But it's always worth remembering that this is looking at one component of the RV, which is the longitudinal function of the RV free wall. The RV is a complex crescentic shaped structure which has multiple components to its ejection fraction, including the RVOT, including the interventricular septum, including the interconnectedness from the left ventricle. So the right ventricular free wall strain is good to assess this part, and it's probably more sensitive than TAPSE and RV strain, RV S prime, but it's always worth remembering that it's only one component of the whole picture of the RV.
Okay, thank you very much to all our speakers. Carlos, if I can hand over to you.
Thank you very much, Steve. Thank you so much for sharing that very interesting and exciting session. And thank you, everybody, for still being with us during this marathon. We still have a couple of 150 people listening to our stream. So for our last session, I'd like to introduce our next chair, Dr. Lloyd Quanten, who is one of our consultant cardiothoracic anesthetist colleagues, and also with a special interest in perioperative echo and ultrasound. Over to you, Lloyd.
Thank you for having me, and welcome everyone to session 5. And this is preparing for the challenges ahead. Sorry, one tick. Preparing for the challenges ahead. Our first speaker is Sue Wright. She's a cardiothoracic anaesthetist at St George's Hospital in London. And certainly she's been instrumental in setting up perioperative echo in the UK. Thank you.
Thanks, Lloyd. Just see if I can. Okay, have you got my slide?
Thank you.
Okay, thanks very much, Lloyd, and thanks to Carlos and Gianluca for asking me to speak. What I'm hoping to do is to give you a very practical account of how we at St George's Hospital went about setting up a POCUS team during the pandemic. And St George's Hospital, as John said earlier, is a 1,300 bedded hospital. And in normal non-POCUS pandemic times, we have about 50 adult critical care beds. Of course, we, like everybody else, were hit by the pandemic. And although there was untold misery that came with it, we have to identify the things that have been positive that have come out of it for us. And from our perspective, we've gained massive amounts of new skill and knowledge, and we've also had forced upon us new ways of working. And I think at the moment we're at the point where we can identify those new ways of working that we'd like to take forward as we carry on post-pandemic, and we're hoping that POCUS will be one of them. The hospital response to the pandemic was to rapidly expand the number of critical care beds that we had. and the number of medical staff who actually took on critical care responsibilities increased by about 60%. So at the height of the pandemic, we had about 130 doctors with critical care responsibilities. The way the medical care was delivered was divided into teamwork, and we had teams for all sorts of things, far more than I've listed here. But we managed to get included in this list of teams, a POCUS team, with recognition that actually there was a lot of interaction between heart and lung effects of the infection, and that an integrated POCUS ultrasound service should have a place in the management of these patients. And the impetus for getting a POCUS team and lung ultrasound in particular included in it was the emerging literature that came from other countries that were a bit ahead of us in the pandemic. So from China, from Italy, where of course there's a strong level of expertise in lung ultrasound. And we already at St. George's had a very excellent structured FICE-focused intensive care echo training program that had been set up by John Aaron. So already quite a high level of expertise in echocardiography. And John really recognized the opportunity to include a POCUS team in the team structure of the critical care response. And he asked James Poesleb, who's one of our echo fellows, and me to co-lead the formation of the POCUS team. So we had a brief meeting in the courtyard of our hospital on a Wednesday, and we raised between us and bounced around discussion about the important factors that we needed to address between then and when we got the service actually up and running 5 days later. And this is probably not a comprehensive list of the things we felt we needed to have a look at and address as we set the service up. And I'm going to run through each of those in turn just to give a little information about what we thought about it and what our experience was in tackling these things. Firstly, manpower. As I said, there was a massive expansion in the number of critical care doctors during the pandemic. We identified 8 trainee grade doctors who were all at the level of FICE accreditation, and 8 consultants, all of whom have echo accreditation of some form or another, either in transthoracic or transesophageal echocardiography. And really pulling numbers out of the air, we decided that each day what we'd like to have was 2 trainee grade doctors, which would form our tier 1 of the POCUS service, and they would be supervised, as it were, by a consultant who was the tier 2 presence on the team. And in the initial stages, we thought we would provide the service between 8 AM and 6 PM daily on weekdays, because we weren't quite sure whether we'd be able to fill rotas to include nighttime and weekend working. And in the event, what happened was that actually we were overwhelmed by the enthusiasm of our trainees. And in the first couple of weeks, we had way more than 2 tier 1 members of the team. And people were coming in on their days off, people were coming in over weekends, and people were even returning to the hospital from other hospitals to which they'd rotated to come and spend a bit of time on the POCUS team. And that made a massive difference to how we set out in the beginning. Of course, despite high levels of enthusiasm, we needed to be quite careful about the level of skill amongst the members of our team. So we made it a prerequisite that people should be at the level of focused intensive care echo accreditation, just to ensure a certain baseline level of skill and knowledge, which was fine, you know, and that served us well for giving credibility to our echo interpretation and image acquisition. But we were slightly worried about lung ultrasound levels of skill, because I think it's fair to say that between us as a group, we had little collective experience and expertise in lung ultrasound. And what this meant was that in the early stages, our educational efforts were quite heavily skewed towards learning lung ultrasound. Actually, for us, establishing joint meetings with Barts, initially a weekly basis, played a massive part in our educational program, because we were able to show our images and discuss our image interpretation with the Barts team. And it's gratifying to know that actually there was a relatively high level of concordance between our aeration scorings across the two hospitals. But above that listed, I've got a lot of online resources, and really there is a lot online, a lot of learning material, and particularly some lung ultrasound courses which had previously commanded a fee. The authors of the courses made them free during the pandemic, and we were able to make the most of that. So in addition to those resources, in the first week, we had tutorials before we started our ICU huddle at the beginning of the day. We already had, as part of John's FICE program, established Tuesday afternoon teaching, and that has continued. We set up a Teams team where we keep a lot of reference documents, links to online resources such as recording. So we record all of our lectures and they go up there, the links to YouTube and so on. Also, luckily, because we had so many people to start off with, it enabled us to double up less experienced team members with people who are a little bit more experienced to help with their learning. We did, for communication, set up a WhatsApp group, which helped a lot, obviously, with organisation and allocation of work. But we did also share images via the WhatsApp group. If we saw something we didn't understand or wanted to discuss, it was a very easy way of sharing images and getting opinions from other people. And finally, we're lucky enough to have a simulator for both lung and cardiac ultrasound. And we could keep a simulator set up in our POCUS hub all the time, so people in their downtime could have a play. Moving on to governance, which is obviously a very big issue in a new service that's set up very, very quickly. As I mentioned, the joint meetings with Barts, actually over time they evolved from being, from our perspective, almost purely educational to forming a governance function as well. That's been invaluable to us. And we've also set up monthly governance meetings, which I think are an important facet of the service as it's new. More informally, we also had, or still have, joint image review between the two tiers of the service each day. And I think that's been very valuable for learning and feedback and keeping control of the quality of the service that we're putting forward. We've also developed protocols to standardize the service, and we hope that this will ensure a degree of quality control, both scanning protocols and also we have a protocol for the workflow. In other words, the kind of thinking that we put into interpretation of our images and what we do with them. So I think, as already been mentioned, the focused ultrasound groups within their parent organizations of the Intensive Care Society and the Society for Acute Medicine have set up a national database in the UK for evaluating heart and lung ultrasound in COVID-19. And we thought that it would be sensible to align our protocols and our reporting with this database. So our standard protocol, as you can see at the top, if you are familiar with FICE, those are the standard FICE views. And then in line with the national database, we included 6 lung zones to scan. And you can see that on our protocol sheet, we've got some prompts to the clinician as to what they should be looking at with each view. Of course, actually, a lot of our team members had expertise that was beyond a basic level, beyond FICE level. And for those who were competent at more advanced scanning, we also had extended protocols. So scanning more zones of the lungs, especially posteriorly, and also adding in extra echo views, particularly looking at the right heart, because obviously, as we've heard in the last session, we expected to see a lot of right heart pathology. This is our standard reporting form. If you've been contributing to the national database, you'll see it's a slightly bespoke version of the database form, with areas for free text for people to enter anything unusual. We decided to formalize to some extent the sequence of events of the scanning process within the POCUS team. So from the top of the chart, from the top of the scheme, where we would attend the joint intensive care huddle at the beginning of the day, that's where we'd receive most of our referrals for POCUS scans. And of course, we'd prioritize patients who needed urgent scans and perform those first before we perform the routine scans that were part of the database study collection. So lung abnormalities on the right-hand side there, we would discuss with the clinical teams looking after the patients. Cardiac abnormalities, what went on after that depended on whether the patients were stable or unstable. Unstable patients, the findings we communicate immediately to the clinical team for urgent management of patients' hemodynamics. And beyond that, of course, we have a specialist pulmonary hypertension team, which is led by Professor Brendan Madden. And of course, in this patient group, we made a lot of referrals to them as well. If the patient was stable but had cardiac abnormalities, we would refer them on to our echo lab for a formal TT study, which was important. It was important that we recognize the focused nature of our POCUS study, but also was important for us in terms of quality control and feedback, because we could look at the subsequent formal study and make a comparison with what we'd interpreted from our own scans. Equipment, this was quick thinking by John at the beginning of the pandemic, when the government actually made a lot of money available to us, to hospitals generally, in order to equip ourselves to deal with the pandemic. And John managed to arrange for us to get 10 new GE venue machines, of which this is one. Really ideal for a POCUS service, because they have the mobile with a small footprint, have a long battery life, touchscreen, which sometimes a little bit tricky if you're wearing 2 pairs of gloves. But also importantly for our lung ultrasound, they have a lung preset, which to me, or certainly in my hands, makes a big difference to what I'm seeing on my lung ultrasound images. Office space might seem a slightly trivial consideration to start off with, but actually it became very important because we had a geographical central point where all of us would meet at the beginning of the day, and usually again at lunchtimes where we would do some image review and discuss the images. And it became a very useful, informal place for the exchange of information. And our POCUS team was actually very multi-specialty in nature. We had cardiologists, we had trauma and emergency medicine physicians, intensivists, anaesthetists, cardiologists, I think I've said them already. And it was great to exchange information, and we all had a slightly different slant on what we were seeing. And I think we benefited hugely from being able to meet centrally to discuss what we were doing clinically. Finally, it's important that there's clinical acceptance and that clinicians actually value a new service that's being set up. And we didn't want people to think that we were just sort of amusing ourselves by performing these scans, but that actually they had a place in the critical care management of our patients. So if we look here at the number of patients that we had at St George's, just looking at patients receiving levels 2 and 3 critical care who were either suspected or confirmed positive for COVID-19 infection. So this is the blue line at the top. The POCUS team actually, you can see from the little arrow at the bottom, was introduced after the peak of our pandemic at the hospital. But what I've divided the display into is the number of scans that we were performing each day. So when we started scanning, there were between 50 and 60 patients receiving levels 2 and 3 care. And in the kind of week to 2 weeks after that, we were performing 7, 8, 9 scans a day. So probably scanning between 10 and 15% of the patients who were in critical care setting. And those that were part of the audit scans, in other words, routine-ish scans that we were performing for the national database. So those were performed on days 1 and day 5 of the patient submission. They're in blue. And then critical care teams were requesting additional scans from us each day, and they're represented in red. And as the number of patients with COVID infection has declined, we see that the number of routine scans has gone right down to nothing. But what I find heartening and interesting is that actually the number of referrals that we're receiving for focused ultrasound scans is sustained. And that is despite having a much lower number of patients on our intensive care units. I think this week there are about 40 patients on our intensive care units, all of them non-COVID, but we're still being asked to scan and perform focus studies on these patients. So in addition to seeing that, we've actually put out a survey asking critical care physicians what they think of the POCUS service. And just to share with you some of the results from the first 40 responses. Firstly, did people find the echo findings useful? Well, over 80% of people did. And to be honest, I think that's not surprising because we have a culture of, excuse me, focused intensive care echo in our hospital. And people are used to integrating the results of focused intensive care echo studies into their management, acute management of patients. And when we asked people about the usefulness of the lung ultrasound, the results were a little bit more mixed. And I think that reflects in part, excuse me, the uncertainty that we've heard about today. Sorry. My last drop of water. The uncertainty that we've heard about today about the subtleties of the findings on lung ultrasound. Sorry, the subtleties of the findings on lung ultrasound and probably our inexperience in interpreting what we're seeing on our lung ultrasound studies. Thanks, my slave's just bringing me a glass of water. So asking people what they thought the good things were that came out of the POCUS service. The greatest value that people put on it was the ability to get a rapid response imaging service for the acute management of patients who'd suffered a deterioration. And going on from that, the POCUS studies were providing useful information for the general management of the patients. People also valued skill development in critical care doctors and also the emphasis of the study findings in terms of being critical care orientated as opposed to a sort of snapshot diagnostic study of a comprehensive scan. Disadvantages, it's tempting to stop there, but there were some disadvantages identified. And I won't dwell too long on it. I mean, I think the main two of interest were that, firstly, people were worried about inaccurate reporting by inexperienced POCUS team members. And we need to take that forward with us in our future planning of the service. And then the next commonest disadvantage that people came up with was that the very focused scans actually gave insufficient information for them to guide management of the patients. Our bottom line question is the best. Really, did the critical care physicians think that POCUS team is a useful addition to the critical care service? And we'll accept that. If more than 80% of our clinicians think it's a useful addition, we will work hard to take it forward. So as a result of that, we've learned that POCUS is valued and that the concerns about the quality assurance mean that we've got to work hard on the training, supervision and governance, and we need to keep these going. It's not something that is just relevant at the very beginning of the service. But of course, like everybody else in every walk of life, we've discovered how valuable online resources and virtual meetings can be. What would we do differently? We would love to have started our service earlier, but the organizational challenges of responding to the pandemic mean that that would have been unlikely to happen. If we'd had time, we'd have done more preparatory lung ultrasound training. And I think some of the comments about insufficient information coming out of our studies means that perhaps we should be leaning towards expecting our team members to perform studies with according to our more extended scan protocols. Sustainability, and particularly with regard to staffing as we go forward, are challenges for us. You know, a lot of our POCUS first tier doctors have been taken back into their parent specialties. So at the moment, although we have far fewer ICU patients, actually we're slightly struggling to cover our POCUS rota. If we are going to get a second surge in coronavirus infections, we've got to bridge the gap to that time when we will regain our personnel. And in particular, our new lung ultrasound skills need to be retained. So it's really important that we focus on keeping those up. So we've gained new clinical skills, which is always satisfying, and we've gained a new specialist service, which is valued. We've all benefited from the multi-specialty nature of how we've gone about it. And last but not least, there's increased interest now already in our intensive care training fellowships, which means that going forward, we'll be able to appoint people who are clinically excellent, but also who have an interest in POCUS. And we think that's got to be good news for the sustainability of our new service. Thank you, and sorry about the coughing.
Thank you very much, Sue. That's a very informative talk, and it's obviously it's good to see the high sort of usefulness of the POCUS findings that you saw in your study. We're going to keep the questions to the end of this session, but I encourage all the participants to continue writing the questions in the question box. Our next speaker is Dr. Andrew Smith, and he's a consultant in cardiothoracic anaesthesia and intensive care at Barts Heart Centre in London. He's got a keen interest in perioperative echocardiography and teaching skills and training. He'll be talking about simulation with POCUS and the interesting topic of where artificial intelligence can assist in interacting, diagnosing and treating our patients. Are you unmuted, Andy?
I am now.
Thank you.
Thank you, and eventually I worked out how to do it. Today, I aim to give an overview of the state of ultrasound simulation and also the developments in artificial intelligence with a particular emphasis on POCUS and COVID-19. And I do need to disclose really that as well as my role as an intensive care doctor and anaesthetist, I'm a paid consultant to Intelligent Ultrasound, and along with Sue, talking just before me, one of the original developers of HeartWorks and BodyWorks, and I will be using a number of images from them during the course of this talk. Since the beginning of the pandemic, the interest in lung ultrasound as a tool to assist us in the management of patients has increased markedly. Many hospitals are using lung ultrasound more often, and with an increase in number of patients in the ICU and the subsequent increase in the demand for scans, the need to train people has also increased and become more important. For those of us that are advocates of point-of-care ultrasound, particularly, say, lung ultrasound in the ICU, this really represents an incredible opportunity to increase awareness, increase training, and increase utilization of the techniques, not just to patients with COVID, but to all patients, both within the ICU and beyond. The training opportunities, however, are limited, and there are limitations on access to the patients in the ICU, patients with infection, and also a limitation to access patients without infection at the moment. Training's made more complicated by the use of protective equipment, and the simulators perhaps offer an opportunity to learn and practice some of the manual components of performing scans. And the simulator industry, the companies in the simulation industry, have rapidly provided examples of COVID-19 infection to their platforms. CAE, with the Blue Phantom, have created a system that allows the user to see simulated ultrasound images with their associated changes. Moving the probe around creates a reasonably lifelike appearance. And 3D Systems, formerly known as Symbionics, they've also created a COVID platform to increase the portfolio on their system. And similarly, the user can perform a simulated ultrasound scan and determine the associated findings, perhaps with COVID infection. Intelligent Ultrasound, using the BodyWorks Eve system, have released a set of cases with varied severity of changes in the appearance of the lung on ultrasound associated with COVID. And you know, we know that the appearances of those findings are patchy and variable, and it requires the sonographer to search in their lung ultrasound scan and recognize the typical findings of COVID-19. And to that end, the simulator platform needs to be able to display both the normal appearances and the various abnormal signs, which you may correlate with severity of decreasing aeration. It needs perhaps to be able to show pleural effusions and illustrate the appearances of pneumothorax. And so this video was partly shown earlier, recognizing the pleural line, the A lines, recognizing the appearance of B lines, whether they are individual B lines or confluent, recognizing the peripheral consolidations, the smaller consolidations, and perhaps the deeper, larger consolidations in the various areas of the lung. And you know, quite obviously, there's quite a lot of variability seen across real patients, and these simulators, you know, currently I'd say they're not a substitute for our training, not a substitute for acquiring experience, but they do offer an addition to our training, and they allow a risk-free entry into the practice of lung ultrasound scanning. And with a combination of the didactic learning, simulator practice, review of both simulated and real scans, demonstration of adequate interpretation, including getting consistent scoring of aeration or loss of aeration, places the candidate in a much better position to perform and learn from real scans in the riskier, more difficult to access ICU environment. And as we've seen through this webinar, the direction of thought is about using point of care ultrasound, whether in ICU or beyond, in an integrated way, integrating information from the various systems being assessed, whether that's cardiac, vascular, abdominal, lung, and the other clinical information. And I suppose it comes back to our traditional paradigm of using history, examination, including investigations, and monitoring to try and reach a more refined assessment of what's wrong and what, if anything, needs to be done in order to achieve a sort of successful outcome. And this includes POCUS, and that really needs to fit into our overall process of managing the patient. And certainly within our current preoccupation of COVID, it has become integrated into many of the areas of care in the ICU for intensive cares that didn't traditionally use a lot of ultrasound. And our training needs to help to show how to integrate these point of care ultrasound scans into our normal workflow. As many of the simulators now have they have cardiac scanning, lung scanning, abdominal scanning. Some of them have vascular scanning capabilities to allow our users, the candidates who are learning, to work out how to interpret these findings in a coherent, sensible context. And as I said earlier, these systems are not likely to replace the current teaching processes, but more to be an adjunct to assist in some of the particularly the early phases of learning, and to perhaps provide platforms to illustrate some of the less frequent, less easy to see ultrasound signs of certain diseases. And we're well aware that the validity of these systems, the face validity, the content validity, hasn't yet been assessed. They're so new to our environment. But if the experience from cardiac scanning is anything to go by, the simulated cardiac scanning, then it's likely to perform reasonably well. I'm going to move from simulators, and it really is an overview of the current state of affairs, to artificial intelligence. And as well as training people to become confident and competent scanners, training them to be able to determine the information, we're increasingly being provided with systems to assist in our interpretation of the scans and to help our subsequent decision making. And the use of AI in assisting radiological examinations isn't new. It's been used in interpreting MRI evaluations of prostate cancer. AI systems seem to improve radiologists' performance when evaluating the ultrasound appearances of malignant lymph nodes. Its performance seems to be equal to expert dermatologists when evaluating skin cancers, common skin cancers and the very lethal skin cancers. And it's shown to be non-inferior to human readers when looking at mammography scans, just to cite a very few broad areas. And it's being evaluated in all of these areas, whether that's lung tumours, liver tumours, brain tumours, or anything, largely with the aim to improve the efficiency and the efficacy of the work done by humans, not necessarily to replace them. To improve the detection of abnormalities, tumours, to better characterise the abnormalities that are found, to help with surveillance and monitoring. And this also now includes the point of care ultrasound environment. Many people will be familiar with the GE system. GE have already built some of these components into their point of care ultrasound platforms. The Venue has the ability to automatically capture a number of elements, certain elements. It can capture the IVC diameter automatically, make automatic LVOT measurement, VTI measurements, and on their lung ultrasound mode can identify B lines and count them. So it's already here with us. this work is being developed further. Other groups, the group in Eindhoven and Trento with Van Sloon, have shown progress in developing AI to identify normal and abnormal patterns. We've got the AI assisted image on the right hand side. Normal shown in blue, and the green, orange and red patterns track the increasingly more abnormal areas of the scan. And this can be done on a live scan. Intelligent ultrasound have progressed along a similar pathway to identify abnormality and anatomy and abnormality. And they've used some of the developments in their other arenas to create AI-assisted lung ultrasound scanning. And so to understand this system, I thought I'd briefly show you some of the components that they've been using to create this lung ultrasound artificial intelligence platform. Now, the anatomy guide is a system used to help with nerve block placement. It functions as a bolt-on to existing ultrasound machines. It's a screen that bolts onto a point-of-care ultrasound machine and uses artificial intelligence processors to identify the anatomy to show the user key structures. Using that additional screen, the AI highlights the anatomy and in a live manner allows the user to see where he should or shouldn't be introducing his needle. This is trained on many images from varied individuals, and the system could clearly provide an important adjunct in the training and the performing of accurate needle interventions, in this case, say a nerve block. But it's not just about identifying anatomy. And one of the other areas of development is in the scan assist system, which takes the concept a little further, using machine learning to recognize the adequacy of the image. Does it contain features that it needs to contain in order to allow meaningful analysis? That are present or absent are indicated to the sonographer in real time, can alter that imaging to ensure that that key data is captured. It's like an automated sort of real-time audit of your scan performance of your imaging. And so the lung ultrasound system being developed by Intelligent Ultrasound works on the same principle as the anatomy guide, using thousands and thousands of images, and the expert evaluations of those images. The system, the machine learned algorithms are created, and they're adjusted so that they reliably identify the required features. And here we will be looking for pleural lines, looking for A lines, looking for the B lines, and so on and so on. But the relevant features on a live scan. So in practice, how does this work? Well, again, attaching a slave screen to the POCUS machine, the AI system draws over the live ultrasound image. So here, the system's able to identify the pleural line and A lines, highlighted in blue here. The system can identify B lines, whether they're single B lines or coalesced B lines, in a live scan. So that these are two of the same scan, one image, the raw data, and the right-hand image showing the AI drawing of the abnormality. We want to be able to recognize those peripheral small consolidated areas, perhaps larger consolidated areas, and the deeper consolidated areas. I don't have an example here and now, but we would want to be able to see pleural effusions and so on. And the idea is that the workflow of the sonographer is broadly the same, but more information is provided to them to either help with the scan or ensure a more complete scan. And I think one of the amazing things is that in a very short space of time, the capabilities of these systems have advanced tremendously. And they really are reaching the stage of entry into the clinical workspace. And one of the purposes of this talk is to perhaps just illustrate the sorts of things that are coming into our environment. And again, they're not there to replace human decision making or human scanning. They're there in a capacity to support our scanning and support the decision making process, perhaps drawing the scanner's attention to areas of abnormality that they may have otherwise missed, or perhaps driving us to more carefully evaluate areas of potential concern. So can it work? Well, the answer is probably yes, and I've just brought up one publication here as an illustration, and this is a paper outlining the use of AI systems to assist in the evaluation of children with pneumonia. And they demonstrated that using the AI algorithm, which will highlight the pleural line, the rib spaces, will highlight areas of normal in green here along green line, or abnormal areas of lung in blue and in red. The AI algorithm can perform really just as well as experts for identifying pneumonia infiltrates, for identifying those areas of consolidation with a 90% sensitivity and 100% specificity. Amazing, really. And the authors go on to say how this technology, might be used to diagnose pneumonia in resource-poor settings where access to expert evaluation may not be so easy, in an environment where childhood pneumonia might be an important cause of death in, say, under fives. So it's technology that might allow evaluations to be performed by people who are less than the absolute experts, the grand masters of POCUS, but allow those evaluations to take place with a support of the AI algorithms to help identify the abnormalities and interpretation. So, perhaps it isn't difficult to see how AI evaluation systems, AI supported systems might help in training and the assessment of individuals, beginning on their journey towards point of care ultrasound expertise. And, we can see how this begins to enable some of the automatic scoring of an abnormality. Just looking at the GE system, automatically recognizing and counting B lines, for example, and taking that further to using systems that automatically perhaps can generate aeration scoring, the generation of visual reports. The GE system uses a visual reporting system. And looking to the future, using this sort of thought process, could this be a monitoring device for recovery from pneumonia? Could we use it to track improvements in aeration? Perhaps calculating the scores automatically, tracking the resolution of heart failure. Could we use it to determine adequacy of ventilation on ICU, readiness for extubation, using I suppose, a more routinely consistent process of evaluating the image through AI platforms? And they all will need validation. We all need to determine how well they correlate with expert review. How often do they miss key findings? How does it perform when you've got various novice and expert people performing the scans? How often do they misinterpret findings? How often do they pick up findings that the sonographer missed? Perhaps, how well do they correlate with the gold standards, with our CT scan? And perhaps just as important or more important, how do they influence the clinical practice and outcome? So I think in summary, and this really is the end of my talk here, AI has moved from being something of the future to being now something very much of the present day. And I think we should be prepared. I would advocate that we should be prepared to embrace and evaluate and incorporate, if appropriate, these systems, these technologies into our developing and growing
point of care ultrasound workspace. Thank you for your attention.
Thank you very much, Andrew Smith, for a very interesting talk about sort of what to expect with the future of POCUS. I understand it's been a marathon of an afternoon. I thank all those listeners who are still with us for this home run session. Our last speaker of the day is Dr. Shran Maroof. He's a general practitioner lead from Reading in the UK. He's part of the team who developed TIC-19, which he'll tell you about. It's a pathway developed with the Royal Berkshire Hospital. And he's going to talk about how ultrasound is used to rapidly triage, assess, and provide follow-up services for those in the community. Thank you very much.
Thank you for having me on. I'm just going to quickly share my screen with you guys. Are you able to hear me okay?
We can hear you, yes.
Fantastic, thank you. Okay. Are you able to see my screen yet?
Not yet. That's it.
Yeah, you've got it. Fantastic. So first of all, I'd just like to say thank you to Carlos and Gianpaolo for giving me this opportunity to speak to you all today. I'm very grateful and humbled to be a part of this experience. And I thought I would just share some of my personal experiences from how primary care has been able to support during this this COVID-19 pandemic, and some of the changes that we've made to our practice to sort of support our communities and our local hospitals. So I guess I'd just like to start off firstly by saying, as the pandemic was evolving in its early stages, it became very apparently clear that primary care couldn't continue to operate in the way that we have been doing for so many years. There was an almost immediate push towards remote triaging in order to minimize the transmission of the SARS-CoV-2 virus, which in itself was quite challenging for primary care as a whole. Locally, we recognized that most practices didn't really have adequate facilities, the provisions for PPE to cover all practices, as well as having quite an aging or vulnerable workforce to assess patients with COVID-19 safely within the community. And the way we did that essentially was a collaboration between local practices through our Primary Care Alliance in developing what essentially was a purely voluntary community service that was developed bespoke to assessing patients with suspected COVID-19 as a way of supporting one another in general practice, as well as trying to help spread more thinly the anticipated pressures that might have fallen on secondary care. We wanted to play our part in minimizing the amount of patients that were flowing into hospitals. As the data suggested, the vast majority of patients ended up having mild to moderate symptoms that didn't necessarily need hospitalization. So we always felt that there was a role for us to play in primary care, and this is the way we felt that we could do it. Within the first 9 days of sitting down and talking to one another within our Primary Care Alliance, we essentially set up this Primary Care Response Hub, which was fully operational thanks to the voluntary enthusiasm of all GPs within our locality, and as well as the support that we received from our local hospitals. Just as we were developing our Primary Care Response Hub, we were largely basing our assessments on the history and examination findings, but it coincided quite nicely with some of the work that was coming out of the Royal Berkshire Hospital, where they had started to develop a virtual ambulatory care unit, where they were seeing patients that had been admitted or assessed initially in the emergency department and were deemed well enough to go home. These patients were essentially sent home with a pulse oximeter, and they were followed up remotely by a team at in the emergency department for about 5 days to ensure that these patients weren't deteriorating and could be brought back into hospital should it be necessary. They recognized that the work that we were doing in the hub could work quite well alongside what they were doing. So we started to collaborate with one another in order to to produce a common pathway and standardize the way that we examined, assessed, and discharged patients with suspected COVID-19. And the assessments that we undertook in primary care largely fell on these four main factors. The first part being a rapid walking test, the second part being a clinical history, third part being the examination findings, and then finally, what we're all here to talk about today, point of care ultrasound for COVID-19. This is just to give you an example of the sort of triage pathway that we had developed in our primary care response hub. And if you look on the right-hand side of the screen, essentially anybody who had significant DE saturation of oxygen on arrival was admitted directly to hospital, but largely patients were coming in with saturations of above 94%. These patients were then put through a rapid walk test of about 30 meters, and we were essentially assessing to see whether they had developed a 5% drop in their oxygen saturations or not. Those that did drop more than 5% were again directed towards the ED department, and that was a pathway that we had agreed between both the hot hub and our local emergency service. Again, largely most patients didn't deoxygenate above 5%, and they were brought into the hub for physical examination and point of care ultrasound. And the point of care ultrasound was a fantastic tool in helping us as an adjunct towards our assessment in help sort of separating which patients were at high risk and which patients were at low risk. So if patients had a negative rapid walking test and normal imaging, they were essentially discharged from the hub unless there was significant concerns clinically from their history or whether they fell into a high risk category. But if they had an abnormal imaging, we would discharge them with a pulse oximeter, and then they were followed up for 5 days in the ambulatory virtual clinic. This is just some of the data that we'd collected within the first 7 weeks of being operational. And you can see from the data that we saw quite significant numbers. 641 patients were referred to our services from local communities, as well as the out of hours teams and some of the occupational health departments within the hospital. And about 42% of those patients were given the diagnosis of suspected COVID-19 based on either their clinical history and examination and their point of care ultrasound. Of the 271 patients that were given the diagnosis of suspected COVID, only 36 of those patients, so 13%, were actually admitted into hospital. So if you look at those figures, 641 patients seen, 36 patients admitted into hospital. And I think the feedback that we'd received from our local hospital was that this contributed significantly in the way that they were able to manage COVID-19 within the hospital itself, and they never really felt overrun at any point. And I'd like to think that the work that was done in primary care helped towards achieving that. What I want to say is, I guess our largest cohort of patients weren't the ones that were drastically unwell or the ones that were very well. The majority of our patients were the ones that fell into that middle category, where they might have had normal physiological findings, but there was some clinical concern or some abnormality on their lung ultrasound. And I think being able to use point of care ultrasound as an adjunct to those assessments definitely helped us feel more comfortable about the way we managed them. And also having that virtual ambulatory clinic gave us the peace of mind that these patients weren't just being sent home and waiting to deteriorate, but rather somebody was calling them on a daily basis to make sure that they continue to improve. I mean, in the first 5 weeks, about 60 of our patients that had suspected COVID-19 were given the diagnosis solely on point of care ultrasound. And these were all fit and well patients around 40 years of age with no significant past medical history. So we were able to identify quite a significant number of patients solely on point of care ultrasound. And from our experiences to date, we've had 2 patients that were admitted to ITU following assessment at the hub. Both of those patients were admitted directly from the hub, but everybody else recovered from COVID-19, and we didn't report any deaths during those 7 weeks. And up until now, we still have yet to report any adverse outcomes from the way we've managed COVID-19 in the community. I do think there is a role for point of care ultrasound going forward, such as models like a virtual hospital or as an adjunct to future assessments, both in practice or even as part of domiciliary care. Primary care physicians are are used to going out to patients' homes, and there is a large proportion of patients who are non-ambulatory, and there is talks within Reading at the moment, in case there is a second wave, to have a team that's available to do home visits as well as point of care ultrasound whilst the patients are at home, in an attempt to try and minimize these patients coming into hospital if it's not necessary. I also think from a primary care perspective, there is a great opportunity to broaden the array of diseases that can be managed remotely using point of care ultrasound. I think some of this has been mentioned by previous speakers, but we see a lot of abdominal complaints in primary care. We also see lots of renal issues in primary care, or urinary tract infections or pyelonephritis. I think some of these patients could be managed within the communities if, for instance, we were able to do a point of care ultrasound on the kidneys and exclude hydronephrosis. I'd feel more comfortable in managing those patients at home or in a virtual setting. And I think there is a positive future with point of care ultrasound, especially in primary care. Unfortunately, there'll probably be issues around commissioning and governance, but I think those are hurdles that we should try to fight, because I do think it has an important role to play going forward.
Thank you very much, Dr. Maroof. That's very interesting. The first question I'll send straight back to you. It's the experience in training non-POCUS users in lung ultrasound and how you went about standardizing a protocol to use.
So when we initially approached about introducing point of care ultrasound as an adjunct to our assessments at the hub, we spoke to Andy and Joe Noonan over at the Royal Berkshire Hospital, who have both been using point of care ultrasound for some time, and they essentially developed a very short training program for GPs to recognize COVID-19 on lung ultrasound. They made it very clear at the beginning, they weren't trying to upscale GPs to do lung ultrasound. We were in the midst of a pandemic and they wanted us to be able to recognize COVID-19 on lung ultrasound as a way of risk stratifying patients and better assessing them. So it was a couple of hours of theoretical teaching. They had some simulators there at the hospital. We got to do some hands-on practice with models and healthy patients. And I think the key was be able to recognize what's normal and what isn't normal, flag that up. And with time, we just grew more and more confident with how to use the point of care ultrasound machines, recognizing pathology. But we also had a safety net in the form of a cloud service. So we could upload images and they could be reviewed by more senior physicians at the hospital if we were unsure about certain appearances. But I think we're sort of 8-9 weeks into using point of care ultrasound now, and most of us who are doing the scanning at the hub are fairly autonomous and are quite comfortable with moving forward using point of care ultrasound.
Okay, thank you very much. The next question's for Sue Wright, and it's a two-part question. The first is it sustainable to have a dedicated POCUS team in the ICU? And the second question is in regards to financing for a new POCUS group. Obviously, people are working in silos, and you mentioned the collaboration between anaesthesia and critical care and emergency. But for new POCUS groups that are just starting up, how would that work between financing with all the different departments and multidisciplinary input involved?
Your microphone is muted.
Are you there, Sue? We just need to unmute the microphone.
Yeah, thanks. Thanks. Did you unmute me? It's a good question. Going forward, actually, I think we're probably less likely to benefit from the multidisciplinary nature of our team. And what we're doing at the moment is putting forward a business case to attract the funding for a dedicated POCUS team, because I think we all feel that there needs to be a team each day whose duties are just POCUS. And we need to have an identifiable base for that team. But actually, we have a lot of support from the clinical care department in our hospital. And hopefully that will help to support the business case for getting funding. So we'd like to have one trainee for a full day and a consultant for a half day each day on the POCUS team. Hoping that'll be successful.
And the last question for Dr. Smith, and obviously we're at the very early stages of what is a rapidly evolving technology. What do you think are the legal ramifications of using this technology to diagnose pathology?
I mean, that's it's a minefield, really, isn't it? And you know, the short answer to that is I don't know. But I think it'll be couched in how these systems are used, and I think the intention is that they're not going to be replacing clinical decision making. They're going to be there as adjuncts, and so I think the responsibility, and probably with an overriding caveat that final responsibility lies with the clinician, or lies with the person performing the scan, or the person interpreting the scan. GE managed to use some of their automatic extraction of data, but they don't provide the final decision as to what to do with that data, whether that data is accurate or makes sense in the clinical context that it's being used. It'll be the sonographer, the scanner, the ITU doctor, or who will carry the responsibility, I think. But yeah, it's a fair question, and in reality, I guess we don't know yet. And it probably depends on what you're asking the machine learning or the artificial intelligence component to be doing. You know, if we're expecting it to try and draw out subtle abnormalities on an image, that's one thing. But if you're expecting it to come up with a diagnosis, you know, that's quite another thing. And I think most of the time, these are decision support aids, not decision replacing aids.
Fantastic, thank you. And thanks to all three speakers for this last session. And I'll hand back to Carlos and Gianpaolo for closing remarks.
Thank you to everybody about the patience to follow all of us. And then I want to thank all of our team that actually made these things happening in a relatively short period of time. And we know, and we noticed actually, that the point of care ultrasound, the lung ultrasound, has been a useful tool from the community up to the ECMO, basically, covering all sorts of aspects of the medicine. And I was also impressed by the fact that people could be quickly upskilled to do something, as we have been doing it here in this hospital, as Stu has done, and as Dr. Maruf has done also in the community. We had the impression that the COVID probably had an excess death, much more than what we expect. And I think will be useful perhaps to upskill more people and more GP in the community, and perhaps even not medical, to recognize signs of the disease in case the second wave would occur. And I really welcome Dr. Maruf's collaboration, for example, to spread his model around other areas in London. There are several GPs that are already interested, and I think with the sort of telemedicine would be possible with all other consultants or people, for example, even the attendees of this conference, that would share an interest to monitor GP or people that wants to be upskilled in the community. I think I don't have anything else to say. I really, really, really thank you all, and to have made this webinar possible. And I really thank you also, Intelligence Ultrasound, to have supported us. Thank you.
Yes, thank you so much. Yeah, thank you to all our attendees. You did really well following this stream for over 6 hours. Thank you. all our panelists for giving up your time, and chairs of sessions to giving up your time on a Saturday afternoon. So this recording will be available. So a link will be sent to you, and also will be available in the Intelligent Ultrasound website. And yes, from Barts, we say goodbye. And I mean, normally we will go to the pub, to the Bishop's Finger, which is just across the square here, but unfortunately it's still closed. I think it'll be opening next week. But yeah, thank you so much, and goodbye.